would like to welcome all of you to the certificate course on menopause being conducted by the ICOG College. And we would like to welcome all the faculty, the delegates, the coordinators, and the conveners. Can we have the prayer song, please? You can stop sharing, Nilima. I'll share the slides.
Hello, can you hear me?
Yes, ma'am. Yes, ma'am. You can.
Yeah.
It's an honor to have the office bearers of Foxy and ICOG joining the program to bless the gathering. It's my honor to introduce Dr. Sheila Mane, who's the Vice Chairperson for ICOG for this year. She is a member of the IMS Bangalore Society and has been the past president of BSOG, past vice president of Foxy, and she's known as a PPH lady. May I request Dr. Sheila Mane to say a few words, please? Madam, you have to unmute yourself.
Thank you, Charmila. And good afternoon, everybody. Yeah. Good afternoon, all of you. And again, it is a real pleasure to see that our certification courses are doing so well. And the scientific program has been structured so well. And today I can see that very important topics are going to be covered, and we have very senior faculty who are going to deliver. And I would like to congratulate all the conveners also, Dr. Geeta Valsarkar, Dr. Shobha Kudi, and Dr. Archana for, being the convener for this program. And I wish all the best for this program today. And thank you, Charmila, for those kind words. And I think we can proceed with are we going to give them the
yes, ma'am. That link will be given,
now?
madam.
The pre-test exam.
Yes, ma'am. Yes, ma'am. Thank you so much, ma'am. And it's my honor to introduce Dr. Parag Biniwale, the chairperson-elect of ICOG for 2025. He was a past president of the Pune Society and he's been the vice chairperson of ICOG. May I request Dr. Parag to say a few words?
Yeah, thank you, Charmila. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to welcome you all yet again for another certificate course. When we think of October, the first thing that comes to our mind is menopause. And being the World Menopause Month, we in ICOG thought we should have a certification course in this increasing problem of menopause. And I must appreciate all the stalwarts from the Indian Menopause Society who've joined hands to conduct this particular program. All of us know that menopause is a big challenge, and 1/3 of a woman's life is spent in a hormone-depleted menopausal phase. So it is important that we understand how to manage them, and we have experts who will be deliberating on various aspects of menopause. So happy learning to everyone, and I hope this program is useful for all the practitioners. Thank you very much.
Thank you so much, Dr. Parag. It's my honor to introduce the secretary of ICOG, Dr. Sarita Bellarao. She's been the president of the Mumbai Society, been the joint secretary of Foxy, and the chair of the quiz committee of Foxy. May I request Dr. Sarita to say a few words?
Thank you very much, Dr. Charmila. It gives me great pleasure to welcome you to yet another course. Last time we had a very successful pelvic floor. We've had lactation before that. And I'm sure that each time we're getting more and more attendance and it's getting more and more popular. So without further ado, I think we can go ahead and I handle back to Dr. Charmila.
Thank you, Dr. Sarita. Thank you so much. The program will be now taken over by the conveners. May I request the conveners to share the screen and start the program. Thank you so much.
Dr. Jaideep will join in between. He's going to let us know as soon as he joins. Yeah?
Okay. The convener for the day can share the screen and start the presentations. Archana, who's the convener today?
Geetha ma'am is there.
No, Shaita, I don't think she's there. You can start.
We can take over from here, no problem. Can we start?
Shall I continue? If Geeta's
Yes, ma'am.
not, yeah, I'll
There's
continue.
Madhuri ma'am has also not joined. So once she joins, I'll introduce her.
No problem. So there are certain instructions for the participants for the program. For the delegates, you got a pre and a post test, which will be in the form of MCQs. And the attendance for all 3 days course is compulsory for the getting the certificate. You will get a Google link for the MCQs in the chat box. And those who have attended for all the 3 days and also passed with 50% marks on each day, they will get the certificate from ICOG. If you're unable to attend the pre-test, it's quite okay, but you should definitely attend the post-test and get a 50% pass to get the certificate. The certificates will be issued within 1 month, and it's just an acknowledgement of your skill and experience, which we do not certify. So please do not think that it gives a blanket approval of everything. You need to keep yourself updated, and this is a part of the ICOG academic program. And the conveners are Dr. Geeta Balsarkar. She's a professor, unit chief from Naurus Jivadia Maternity Hospital and GS Medical College, Mumbai. She's the secretary of the Mumbai Society, as the past editor-in-chief of the Journal of Obstetrics and Gynecology in India, Jogi. The second convener is Dr. Shobha Gudi. Madam has been the past president of BSOG, chairperson of the Family Welfare Committee of FOXY, and secretary of the Bangalore Menopause Society. The third convener is Dr. Archana Dwivedi. She's the chairperson of the Midlife Committee of FOXY from 2025, has been the president of the Baroda Society and past president of, has been the secretary of WDW India, as well as the founder of MSV, founder president of MSV. May I request the conveners to take over the program, and the preamble will be given by Dr. Geeta. But as Dr. Geeta has not joined, I request Dr. Archana Dwivedi to take over the program.
Geeta has joined.
I'm there.
Okay.
Yeah, I'm
Geeta,
there.
you can continue, Geeta. Thank you so much.
Continue from here.
Okay. Basically, Charmila has already explained like whatever is the course going to be, how there's a program for 3 days, how every day the program starts at 4 o'clock and will be there till 7 o'clock. There is a pre-test and a post-test, and we request all the candidates to take both the pre-test and the post-test. And it is very, very important to stay updated with this very important topic, that is menopause, wherein we need other specialities also to collaborate with us, like the cardiologists, the physicians, the endocrinologists, the psychiatrists, and with the increasing population, geriatric population of India, we need to keep ourselves updated with whatever is there in the menopause. So this is a very important initiative from ICOG to keep updated with the up-to-date knowledge.
You can put the link now, Nilima, and put the timer also.
Okay. Yeah. Gauri, please put the link in chat box.
Put the timer also.
Yes, ma'am.
And mute all others disturbances.
Yes, ma'am.
Yeah.
Hello. Hello.
Madam, the assessment is going on, madam, so there'll be silence, madam. Geeta, you can start the academic session.
Shall we start now?
Yeah, please.
Yes.
Yeah, please start. Dr.
Yes,
Shobha Gudi, she's there, no? She's the coordinator for today's session. Shobha?
No, ma'am, today is Dr. Geeta ma'am, but I think Madhumita Geeta ma'am is there.
Yeah, no, I'm there, but it is Dr. Shobha who is going to do it.
Okay.
The coordinator can start.
Yeah, you can start. I'm there.
The session. No problem.
Okay.
I'm there, you can start.
Yeah, Madhumita,
Yes,
start.
Thank you, ma'am. So moving on to our academics today, we'll be having 3 sessions with 3 talks in each session. For the first session, we have our respected allied chairpersons, Dr. Sadhana Gupta ma'am and Dr. Rajat Mohanty sir. So
Team, please unmute Shobha ma'am. She's not able to unmute herself.
yeah. Dr. Sadhana Gupta ma'am, she's the co-chair of SUFOG NCD committee and also the FOXI representative to SUFOG. And she was vice president of FOXI in 2016 and past chairperson of FOXI Safe Motherhood Committee. And Dr. Rajat Mohanty sir, he was the convener of ASCOG 2002 and he's the national coordinator in endometriosis committee and the chairperson of midlife management committee in 2012 to 2014. I request the chairpersons to please introduce the first.
Hello, Madhumita. Can I say something?
Yes, ma'am.
Madhumita? Yeah.
Yes, ma'am.
So, we are very honored to have Dr. Sadhana Gupta and Dr. Rajat Mohanty as chairpersons. Dr. Mohanty has communicated that due to the impending tsunami in his area, there are a series of government meetings and he may not be free and may not have the connectivity. So, has he joined? Has anybody seen him join?
No, ma'am, not yet.
Yeah, so we request, you can request Sadhana madam to take forward. Dr. Sadhana ji, yeah, thank you.
Thank you, Shobha, and my regards to all dignitaries, Dr. Jaideep Tang, Dr. Parul Kotawala, Dr. Madhuri Patel, Dr. Sheila Mane, Dr. Sarita Bhalera, and Dr. Parag, and all series convener, Dr. Charmila, and all conveners and the coordinator. So, a great opportunity, and these certified courses are very much looked forwarded by all people across the country. And the beauty of this is that it is an in-depth discussion and in-depth knowledge, as well as the test of the knowledge that what the students or what the members who have joined, how much they have grasped. So a great appreciation and congratulations, especially to Dr. Parul, Dr. Parag, Dr. Sarita, and Dr. Sheila Mane. Today, it is a great pleasure to have introduce the first session, that is the inaugural session, which is going to deal with the very basics. And the basics is something which seems simple, but always it has got a lot of intricacies. And once we understand that what is normal, what is a little bit variation from the normal, then it gives us a real insight that how we deal with our day-to-day patient. And the FIGO is today, and the FOXI as well is committed that the menopause is the time where really positive life intervention and the sensitivity of the healthcare provider can do a lot for our post-menopausal women who constitute a great number of our Indian population and all the global population. So Dr. Shaijas P, a very dynamic chairperson of Midlife Managing Committee of FOXI, a multi-talented person from sports to music to academics and a organizer. He has been also chair of research committee of Kerala Federation of Obs-Gynae and past joint secretary for the KFOG, and he has graced as a president of the Kannur OB-Gynae Society in the Kerala. So he has done brilliant work as a midlife committee chairperson, and Dr. Shaijas is going to have the defining menopause and how we stage menopause. for setting the context for further discussion. So welcome, Dr. Shaijas, and we are eager to listen to you.
Thank you. Thank you. Thank you so much, Sadhana Madam, for those kind words. First of all, my greetings to the Foxy President, Dr. Jaideep Tang, the Chairperson of ICOG, Dr. Parul Kotadwala, sir, the Secretary General of Foxy and the Editor-in-Chief of Jogi, and none other than Dr. Madhuri Patel, Madam, the Vice Chairperson, Dr. Sheila Mane, and the Secretary of ICOG, Dr. Sarita Balirao, the series conveners, dear Parag sir, as well as Charmila Madam, the international faculty, Dr. Hari, who's here with us, as well as all the three wonderful conveners who have been doing a lot of good work for ICOG, Dr. Geeta Madam, Shobha Madam, as well as Dr. Archana, who will be taking over the midlife committee from me, as well as the coordinators, Dr. Archana, Dr. Prerna, Dr. Madhumita, as well as Dr. Priya. Shall I share my screen?
Yes, sir.
Just a second. Is my slide visible?
Yeah.
It's visible. Yes, now it's okay. It's full screen.
Okay, okay. I hope I'm audible too.
Yes,
You are
sir.
very much audible.
Thank you, thank you, thank you. Thank you. So on that note, let me get started. I bring greetings from Foxy as well as ICOG as well as this society at Kannur of some vibrant members, almost 140 of them who have been doing a lot of good work. As well as I bring greetings also from Kerala Federation. Now we have thank you for making me the opening batsman. I hope I can get started with this series of lectures as part of the ICOG online certification course. We are discussing a very important topic, that is menopause. When that lady feels that all the heat in the world is within her, we are attempting to define it and stage it in the best manner possible. Now, there are various definitions of menopause that have come up from across the world. Some basically meant for the public. That would be something like this, that a natural menopause defined as permanent cessation of menstruation resulting from the loss of ovarian follicular activity. Then the WHO came in and formed the scientific group on research in menopause, which wanted to define menopause a little bit more better, especially for research purposes. And they brought in a few interesting definitions. Obvious pathological or physiological causes could be determined. Basically, it meant 12 months of amenorrhea, and it being a retrospective diagnosis. No independent biological markers is what they taught, and the only objective sensitive marker could be irregular menstrual cycles. And they thought that there was no need to conduct tests routinely to diagnose menopause. Now, this was as per the WHO definition. You can look at the phases of menopausal transition, then menopause, and then this entity called postmenopause, and then the perimenopausal period. On the first look itself, the overlap of most of these phases is something which would be striking. So they attempted to define it a little bit more better. Postmenopause, the period following the final menstrual period, regardless of whether menopause was induced or spontaneous. They defined perimenopause as the period immediately prior to the final menstrual period, when the endocrinological, biological, and the clinical features of approaching menopause would commence. Also include the first year after menopause. And then this term called menopausal transition, otherwise known as climacteric, the period of time before the final menstrual period when variability in the menstrual cycles is usually increased. Now, there's always this question, are lab tests required? Though we knew that some lab test had a value, something like a serum FSH value of more than 40, a serum estradiol value of less than 20, an AMH or an inhibin B value which is low, and an ultrasound which showing a reduced antral follicle count could be used. But then it was recommended that it could be used, it need to be used only when there are fertility issues in this woman, or in very specific scenarios where the clinician feels that these tests need to be done to confirm. Otherwise, routinely, these lab tests are not required. Now, were these definitions from WHO good enough? There were definitely limitations. One is they had very vague starting points. So you never knew when the lady went from one phase to the other. And the terms premenopause, perimenopause, menopausal transition, and climacteric to some extent had overlapping time periods. And this lack of a very clear and objective criteria to describe the stages of female reproductive aging led to the stages of reproductive aging straw classification in the year 2001. So, but before I actually get into the straw staging, I think there definitely need to be a mention of this man. Any guesses?
Dr. Behram Anklesaria.
Perfect. I don't think we should have any presentation on staging and definition of menopause without mentioning this legend. He happens to be the 43rd Foxy president who was installed in Agra in 2004. And he came up with one of the first ever staging of menopause ever published in the world. And to remember that a Foxy president has been behind it, it was an Indian behind it, I think it should give us a lot of pride. And these are his words from one of his earliest publications, which came in the Journal of South Asian Federation of Menopausal Societies. He said, I quote, "Ever since my earliest involvement with the Indian Menopause Society, I was troubled by the fact that no staging system for menopause was published anywhere in the world. I found this very strange because it is obvious to me that the clinical events occurring in a woman's life around the time of menopause are progressive endocrinological changes. So in the first staging system ever published, and that was in the year 1997. So remember that the straw staging came in 2001. So this is much, much earlier. I divided the menopause transition into 3 stages, each with a duration line, an events line, and an action line. So loads of respect to Dr. Behram Anklesaria for being the first one in the world to actually think of a staging system for menopause. And this was the original classification which he came up in 1997, which was published in the same journal which I just mentioned. There was a stage 1, a stage 2A, stage 2B, and 3. We would not go too much into detail, but then this was a very interesting staging system, which actually talked about a lot of components, though there were some limitations, and IMS did come and collaborate and did a little bit of modification to the staging system, which came up as a revised system later. But I think it was a real mammoth effort, and only a legend could actually stage it in this manner when none of the other people who have been doing a lot of work in this field would ever think so across the world. Coming on to the straw staging, which came up in 2001. Now, this separated the stages of female reproductive aging into 7 distinct segments. This is particularly meant to focus on healthy women undergoing natural menopause. Though it was particularly meant to be there, this actually was thought to be one of the limitations to the staging system, and that is why it went ahead from this original staging system which came out in 2001. Now, furthermore, menstrual cycles, endocrine and biochemical factors, signs and symptoms in other organ systems, and uterine and ovarian anatomy were used. Now, this is the straw staging system which came out in 2001. If you look at it, there are 5 stages before the final menstrual period and the 2 stages after the final menstrual period. Further subdivision is into reproductive phase, menopausal transition phase, and the postmenopausal phase. Reproductive phase being further subdivided into early, peak, and late, which are -4, -3, and -4, -5, -4, and -3 as per the numbers. Menopausal transition further subdivided into early and late, which are -2 and -1 respectively. Post-menopause, again, further subdivided into early and late, which is +1 and +2. Okay. And you will understand from this classification that there were primarily two criteria used. One was a clinical criteria, which was the regularity of the menstrual cycles, which are seen here, and then a single endocrine marker, which was FSH. Okay, and then we also looked at the stage duration in years. So menstrual cycles was the clinical parameter, the endocrine parameter was FSH, and it was classified like this: -5 to -3, pointing at the reproductive phase, -2 to -1 at the menopausal transition, and +1 and +2 looking at the post-menopausal phase. Now, there were some limitations to the STRAW 2001 classification. Now, one is only FSH was considered as a biomarker, with relatively little clarification about the precise timing of change in FSH levels or quantitative criteria for FSH. So this criteria primarily focused, as I already mentioned, on the menstrual bleeding pattern and qualitative FSH assessment. It did not actually have a cutoff FSH value. That means there was no quantitative assessment done. The other important limitation, as I already mentioned earlier, was its exclusive applicability to healthy women. That means it could not be applied to a woman who either smoked, who had a BMI less than 18 or more than 30. That means none of the extremes, could use it. Could not be applied to a woman engaged in heavy exercise. Could not be applied to a woman who had chronic menstrual cycle irregularity. Could not be used for a woman who had a prior hysterectomy or had abnormal uterine anatomy, something like a fibroid, which is so very common, or somebody with an ovarian pathology. So these were big limitations. So only for healthy women it was useful. So it definitely required some revision and improvisation. And thus came in the new STRAWS classification, which came up in 2011. Okay, it was called the STRAW +10 classification. Easy to remember, though it is actually based on the number of stages, because the initial one had 7 distinct segments. So there were, it was called +10. But if you want to remember the years also, it was 2001 in which the initial classification came. So add 10, so that means it is 2011 in which the STRAW +10 classification came into being. Something for you to easily remember. Now this basically, on the first look, it might look the same as the 2001 classification. But remember that there were some changes. One is this late reproductive phase was divided into subtle, two subcategories, -3B and -3A, basically looking at the changes in the regularity of the menstrual cycle. Okay, so -3B and -3A based on whether cycles were regular or did it start showing some subtle changes. And then you come here and you'll find that the early postmenopausal phase was subdivided into 1A, 1B, and 1C. That is +1A, +1B, and +1C. So that was another change. And then they did bring in a little bit more clarity to the alteration in the variability in the menstrual cycles. Okay, that means this, especially the phase called the late perimenopausal phase, pointed at 60 or more days of amenorrhea. And there was a very quantitative cutoff to the FSH level of more than 25. Okay, let's look at a little bit more of the description of this. Now, the late reproductive stage, -3, as I already mentioned, is subdivided into -3B and -3A based on the menstrual cycle characteristics and FSH levels, which I hope you would have already understood. Now, this is primarily done to recognize those subtle changes in the menstrual cycle. Secondly, this proposed a more precise menstrual cycle criteria be used to describe the early and late menopausal transition. Okay, go back and look at this. Okay, early and late menopausal transition phases. Early, there is variable length, and late when there is 60 or more days of amenorrhea. This is what I'm talking about. Okay, fine. So early or late menopausal transition based on strict criteria. Specifically, early menopausal transition, that is -2, was discernible from the late reproductive stage, that is -3A, due to an increased variability in menstrual cycle length. What did they try to say? They are looking at this -3A to -2. In -3A, there are subtle changes in flow and length. and in -2, there is a variability in the cycle regularity. So this is what they were talking about. Now, the variability was better defined, as rightly mentioned, as a difference of 7 days or more in the length of the menstrual cycle, which is persistent. That means this variability, this variable cycle length reoccurs within the next 10 cycles. Okay, so there is a variability and there is a reoccurrence of that variability within the next 10 cycles of the first variable length cycle. Fine. So that was better defined. Basically the same. Now, the other two important things to be told are, one is the late menopausal transition, that is -1, was marked by an interval of amenorrhea greater than or equal to 60 days, in addition to an increased FSH level greater than 25. Let's go to -1. Yes, as I already mentioned, 60 or more days of amenorrhea. This is an improvisation from the STRAW 2001 and a definite quantitative assessment and a cutoff for FSH value, a value more than 25. With this, would tell you that she's in the late perimenopausal transition phase. Okay, late menopausal transition phase. Okay, fine. Now, finally, early postmenopause, that is +1, as I already mentioned, is further subdivided into 3 stages, 1A, 1B, and 1C, to account for the continual increase in FSH and a decrease in estradiol for 2 years after final menstrual period. We'll go back and understand that, okay? Look at this, postmenopause, early and late. This is there in the earlier classification also. Subclassified into +1A, +1B, and +1C. +1A is actually for 12 months after the final menstrual period. And then +1B is for another 1 more year. Put together, 1A plus 1B would constitute 2 years post the final menstrual period, okay? 2 years post the final menstrual period. From the 3rd year onwards to 6 years is 1C plus 1C. And what happens here is that the FSH level tends to stabilize, okay? So variable FSH levels in +1A and +1B, that is for almost 2 years after the final menstrual period. And then it tends to, FSH level tends to stabilize. And from then on, you enter the +1C, which is the later half of the early postmenopausal phase.
Sorry to interrupt you, sir. Your time is up.
Yeah. I'm just finishing. It's just one
Yeah.
more slide. Okay. Yeah. And then we enter the late menopausal phase. Okay, fine. Now, there are certain limitations to the STRAW 2011 classification also, which definitely has a scope to improve. The STRAW +10 staging system, this was a good thing, was found to be applicable to most women regardless of age, demographic characteristics, body mass index, and lifestyle characteristics. This was a limitation for the 2001 classification, which has been overcome by the 2011 classification. The areas to improve are, we need to use some standardized assays for key biomarkers like AMH, which is something that we face in fertility practice also, because the assays doesn't seem to be standardized. Every lab seems to be using their own. Then there need to be an empirical analysis to specify the menstrual cycle criteria for the late reproductive stage. Okay, that is something we need to look at. And then there is definitely need to be further research, at reproductive aging in women who have had either a removal of a single ovary, or women who have had a hysterectomy, or suffering from chronic illness like HIV infection, somebody who's on onco treatment, somebody who has polycystic ovarian disease and premature ovarian failure, because these are certain factors which could affect the staging system. Another critical limitation is that STRAW +10 criteria do not apply to women who are on HRT, and that is something which we need to work on. So what has been our journey and what lies ahead? We have moved from the Ankylosarria classification, the Indian legend, then the WHO attempting to define it, then the STRAW 2001 classification and the STRAW 2011 classification, and the search for an ideal classification is still on. So still STRAW 2011 with certain limitations seems to be the one which is being most commonly used. And I hope probably in due course of time, with more data coming up, we'll have better and better classifications in the years to come. Thank you so much for a very, very patient listening. I hope that served the purpose.
Thank you so much for that clear and informative talk on menopause and its staging, sir. I request Sadhana Gupta ma'am to give your concluding remarks.
Hearty congratulations and appreciation, Shaidas, that first of all, you make a little bit monotonous subject very, very interesting. Great thing that you have mentioned Dr. Behram in the right context, what his role should be. and how the straw system, and Dr. Anklesarea, he was really visionary. So straw system evolved with our or scientific advances like our biomarkers availability and in the imaging availability. One point, Dr. Behram Anklesarea classification, which is actually still above the straw classification, that he in the last section also says about what the clinician should do. So it is a treatable, what you should know, and that is the add-on thing which is still remains with the Dr. Anklesarea classification. And I hope that we all together will make a good thing about Dr. Behram, because it is one of the very innovative and very, very thoughtful contribution. The third thing is that, yes, we divide, and what you ended the talk with this thing that we have lacuna, and it is bound to happen, because finally it is a biological clock. The nature has said, nature is never right from childhood to our old age. It is a continuum. And as a health practitioner, we want to understand that what we should do in this period. And that's why we must have a very clear knowledge that in that period, what the person, what treatment or what support the patient requires. And the MHT, the latest guideline, but why this classification and your presentation is very, very significant, because Cardiology Association, Menopause, OB-GYN, orthopedic, this is the one thing that when MHT, so all classification is that within 5 years and what is BMI after 5 years, after 5 to 10 years of menopause. And that is like a need for the very clear understanding by all clinicians, that we understand this biological clock and intervene what is needed at that moment of time. So wonderful, great to hear you. And you have really made a century, like it is 20 by 20, so all 20 balls. So thank you. So
Thank you. Thank you. Thank you.
Yeah,
Just one
Madhumita.
information I wanted to add.
Fine. Yeah, can we take in? Yeah, Maninder, can you be a little quick because we are running out of time?
Just one line only.
Yeah.
Dr. Bairam Anklesaria's original classification was published in Jeffcott Book of Gynecology. That chapter was written by me. The first chapter is the gynecology book.
Thank you, Maninder. Thank you.
Later on, it was edited, but that was the original one.
Thank you. Thank you for the information.
He is
We
the
shall now
father
go
of
ahead.
Indian Menopause Society. Yeah.
Yes. We acknowledge that. And we'll go ahead with Dr. Lakshmi Srikhande's presentation now. Dr. Lakshmi is, yes, Madhumita?
Yes, ma'am. So, Sadhana Gupta, ma'am, Dr. Lakshmi Srikanth will present the
Please
next
introduce, Dr. Sadhana, please introduce.
So a great pleasure to introduce Dr. Lakshmi Shikhande. We had a very, very long association, and I think I have her all achievement on my tips. She has been a very dynamic, brilliant, immediate past chairperson of ICOG, national corresponding editor of OB-GYN, our own journal, and Association of Medical Women of India, joint secretary, Indian Menopause Society. And she has been vice president elect for like ISOPAP 2016-17 and president of ISOPAP Vidab chapter. So she has graced many, many positions. She has been the president of Association of Medical Women Nagpur and contributed a lot in the FOXY, in the CEFOG, and she has been the senior vice president FOXY 2012. Awarded with many fellowships, many achievement award, best committee award for the chairperson HIV/AIDS, and a lot of appreciation from the government, and delivered 32 oration and 550 guest lecture. So welcome, Dr. Lakshmi Shikhande, and I think you are going to talk on the premature menopause.
No. Thank you. Thank you, Sadhana, for your generous introduction. Friends, my topic is cancer prevention.
Okay.
And when we say prevention, it is the action taken to lower the chance of getting cancer. And there are various ways to prevent cancer, including lifestyle changes, avoiding the risk factors, taking medicines to treat a precancerous condition, or to keep cancer from starting, and risk reduction surgery. When it comes to menopause and cancer, remember, menopause does not cause cancer, but the risk of developing cancer increases as woman ages, especially ovarian and breast cancer. women who have gone through natural menopause are more likely to develop cancer because they are getting older. So straightforward, I am coming to the ovarian cancer. It is the 8th most common cancer and the 7th most common cause of cancer death in women worldwide. A woman's risk at birth of having ovarian cancer sometime in her lifetime is nearly 1.5%, and the risk of dying from ovarian cancer is almost 1%. Approximately 30% of ovarian neoplasm in postmenopausal women are malignant, whereas only 7% of ovarian epithelial tumors in premenopausal patients are frankly malignant. So currently, we don't have any reliable screening test as far as ovarian cancer is concerned. We can go ahead with the yearly routine pelvic examination, transvaginal ultrasound, and serum CA-125. It can be done in selectively high-risk women only. This is the age-wise distribution. If you can see, the risk factor for ovarian cancer increases as her age increases. Another risk factor which we can keep under control is if the woman is overweight or obese, because obesity has been linked to a higher risk of developing many cancers. Also, obesity has a negative effect on the overall survival of a woman with ovarian cancer. If she has children later in life or she never had a full-term pregnancy, again, this is a risk factor for ovarian cancer. If she has taken menopause hormone therapy, again, her risk increases slightly. If she has a family history of ovarian cancer, breast cancer, or colorectal cancer, then she is more likely to have a ovarian cancer. If she has a family cancer syndrome, that is a family history of some other types of cancer, such as colorectal cancer and breast cancer, is linked to an increased risk of ovarian cancer. This is because cancers can be caused by an inherited mutation in certain genes that cause a family cancer syndrome, which increases the risk for ovarian cancer. Now, there is a hereditary breast and ovarian cancer syndrome. So, this is linked to a high risk of breast cancer as well as ovarian, fallopian tube, and primary peritoneal cancers, and the lifetime ovarian cancer risk for women with BRCA1 mutation is estimated to be between 35 to 70%, whereas with BRCA2 mutation, the risk is estimated to be between 10 to 30% by the age of 70 years. If she is using the fertility treatment to get pregnant, she is at higher risk for developing ovarian cancer. And if she had a breast cancer, then also she is at increased risk for developing ovarian cancer. Now, once we know the high risk factors when she approaches us in our OPD, now the question comes, whom should we go ahead and screen for ovarian cancer? So this is the list, the categories whom we should screen, that is peri and postmenopausal woman, if she is more than 50 years of age, if she is nulliparous, if she had history of PCOS, woman with family history of ovarian cancer, women who are having personal history of breast and colon cancer, and women with BRCA1 and BRCA2 gene mutations. So women who appear to be at high risk for ovarian cancer, they should be offered genetic testing for BRCA1 and BRCA2, and positive women, that is BRCA1, BRCA2 positive, they who have completed their family, they should be recommended to undergo prophylactic bilateral salpingo-oophorectomy. Again, as far as ovarian cancer is concerned, we as a treating clinician, we should have a high index of suspicion because it comes with vague symptoms. The symptoms of ovarian cancer are abnormal vaginal discharge, bleeding after menopause, bloating or swollen feeling in the stomach, feeling full, urinary frequency, constipation or changes in bowel movements, discomfort in the pain or pelvic pain, and fatigue. So these are very, very common symptoms, but we should have a high index of suspicion. So friends, this was screening as far as ovarian cancer is concerned. That is, we should have high index of suspicion. We should look for the risk factors, and those who are having risk factors, we should go ahead with the yearly screening. Now coming to the breast cancer. We all know that there are certain factors which increases the risk for developing breast cancer. Remember, having many risk factors does not mean that woman will develop breast cancer. On other hand, having no risk factors does not mean that she will not develop the disease. So we are just talking in terms of probabilities when we are talking about the risk factor. Age is the single most important risk factor for breast cancer. Personal history of breast cancer or benign breast disease is another risk factor. Inherited risk of breast cancer if she is having a family history of breast cancer in a first degree relative, that is mother, sister or daughter. Women who have inherited changes in the BRCA1 and BRCA2 genes or in certain other genes, they are also at high risk for developing breast cancer. Now, if she is having dense breast tissue on a mammograph, then also she is having a risk factor. But this risk depends on how dense the breast tissue is. Women with very dense breast, they have a high risk of breast cancer than women with low breast density. We have to take her reproductive history in greater detail because the more she is exposed to estrogen, then more she is likely to have breast cancer. So the woman who has early menstruation, who has late menopause, or who has older age at birth of first child, or who has never given a birth is more likely to have breast cancer. Taking MHT, again, we have to balance the pros and cons before we start MHT, and we have to counsel her as far as her risk for breast cancer is concerned. If she has taken radiation, especially at the time of puberty on the chest, then also her risk for breast cancer increases. Obesity is another risk factor. Lifestyle, yes, alcohol, smoking, they have been considered as a risk factor for developing breast cancer. Now, there are certain protective factors also for breast cancer. So, the reproductive history, which results in less exposure to estrogen, like early pregnancy, if she is doing exclusive breastfeeding, these are protective factors. Now, there is a chemoprophylaxis, the concept which has come up as a protective factor for breast cancer. That is taking SERMs or aromatase inhibitors. So, tamoxifen and raloxifene, they belong to this category of drug, and tamoxifen lowers the risk of estrogen positive breast cancer and ductal carcinoma in situ in premenopausal and postmenopausal women who are at high risk. Women who are younger than 50 years who have a high risk for breast cancer may benefit from taking tamoxifen. Of course, you have to consider the side effects and the pros and cons before starting tamoxifen. The risk of endometrial cancer lasts for 5 years after tamoxifen is stopped. Another drug in this category is raloxifene, and taking raloxifene does not appear to increase the risk for breast cancer. Now, another chemoprophylaxis drug is aromatase inhibitor. So these aromatase inhibitors, they lowers the risk of recurrence and of new breast cancers in women who have a history of breast cancer. Just a minute. Aromatase inhibitors also decrease the risk of breast cancer in the woman with following conditions, that is postmenopausal woman with a personal history of breast cancer, women with no history of breast cancer who are 60 years and old, but who have a ductal carcinoma in situ with mastectomy, or who have a high risk of breast cancer based on Gale model. In women with an increased risk of breast cancer, taking aromatase inhibitors decreases the amount of estrogen made by the body. Possible harmful effects should always be taken into consideration. That was chemoprophylaxis. Now coming to the surgical aspect. So the risk reducing or prophylactic mastectomy, whom it should be offered. Some women who have a high risk of breast cancer may choose to have a risk reducing or prophylactic mastectomy. After surgery, the risk of breast cancer becomes much lower in these women, and some women who are diagnosed with breast cancer may decide to have a healthy breast removed, that is contralateral prophylactic mastectomy. Now there is a prophylactic surgery called as ovarian ablation, and the treatment that stops or lowers the amount of estrogen made by the ovary, including surgery, is called as ovarian ablation. This decreases the amount of estrogen made by the body and therefore lowers the risk of breast cancer. However, it is very, very important to have a cancer risk assessment and counseling before making this decision. As far as hormonal contraceptives are concerned, it is not clear whether they increase the chances of breast cancer or not. Coming to the breast self-examination, I will just take 2 minutes. Breast self-examination was initially proposed as an intuitive, inexpensive, non-invasive, and universally accessible means of promptly identifying early-stage breast neoplasm, but current media literature does not support the efficacy of this practice, and the general implementation is being discouraged by most medical societies and academics. International groups have also suggested that breast self-examination may benefit certain population in developing countries where mammogram is not easily accessible. So the indications for breast self-examination remains controversial, but it has been suggested that it might help in certain group of population. When to do is very, very essential. You have to tell women that it has to be an accurate, repeatable, and comfortable process. Should be done same time every month, ideally at the end of her menses. But if she is amenorrheic, it should be done on the same selected date each month. How to do it? This is the diagram. Are there any complications of breast self-examinations? Friends, I will say yes. These are principally secondary to the false positive findings resulting from the breast self-examination in the form of increased benign lesion identification, unnecessary imaging that she is subjected to mammography, unnecessary biopsies, and the anxiety which has been provoked by a possible cancer diagnosis. Mammogram is another screening tool, remember, but it has also its side effects in the form of overdiagnosis, in the form of additional unnecessary tests, and also in the form of unnecessary biopsies and anxieties. So what is the recommendation? For women, those who are at average risk, the guidelines are telling to start mammograph at age 40 and then get at every 1 to 2 years till the age of 75. The decision to continue or stop screening should not be entirely based on the age. This is the American Cancer Society screening recommendation for women at average breast cancer risk. And here also they are saying that clinical breast examination has no role. Mammography, according to the age, they have given when it should be done, when it should be started, and how frequently it should be done. Now there is a 3D mammogram as well. Many studies have found that 3D mammography appears to lower the chances of being called back after screening for follow-up testing. Now the women who are at higher risk for breast cancer, they are based on certain factors. They should get their breast MRI done and a mammography every year, typically starting from the age of 30 years. If you are using MRI, it should be done in addition to and not instead of a screening mammogram. So these are the various tools which are available online to assess the risk of breast cancer in that particular woman. So friends, I was told to concentrate only on the breast and ovarian cancer, and in general, the cancer reduction strategies, now lot of emphasis is given on the lifestyle factors. So these are the general cancer reduction strategies, that is maintaining healthy weight, doing exercise regularly, having a healthy diet, limit your consumption of alcohol, stop smoking, and various other things, including taking tamoxifen or raloxifene in cases of high-risk women for breast cancer. So to conclude, menopause does not cause cancer. The incidence of female genital organ malignancy increases with the age. Among the gynecological cancers, we all know that breast cancer tops the list, followed by ovarian cancer. Most of these postmenopausal women are not aware of these malignancies and their symptoms, and hence they come to us at an advanced stage. So it is our duty as a clinician to increase the awareness, to tell them about the screening, and we should do prompt evaluation and treatment in these postmenopausal women. Thank you, friends. Thank you so much for your patient hearing.
Thank you for that clear and informative talk, ma'am. I request Dr. Sadhana Gupta, ma'am, to please give your concluding remarks.
Thank you, Dr. Lakshmi. It was a really vast topic because every cancer have got a lot of intricacies, and no professional bodies is actually, they are consensus, either it is ovarian or it is a breast cancer, what you have focused. Important thing is when we have just lost a doyen of the cancer treatment in our country, that is Ratan Tata, and some things we can say that in reality that how the committed people can make a change. And this is one of the very important issue because the India and South Asia, what we can say low middle income countries, we are bound to get more cancers, and the people are more likely to get suboptimal care in cancer treatment, and the prognosis in our countries and the reason is not that good what is in the developed country. So your last slide was wonderful, what we can do, and we have to promote actually these things like the low fat diet, no smoking, a good at the right age you have the one or two child bearing, and then the breastfeeding, which are actually adding to protection of many cancers. Beside this mammography, very beautifully you have taken this all intricacies that how mammography is and the breast examination are not without their own risk and the secondary more invasive procedure. And especially in India, when our women get cancer at 10 years earlier, women have more dense breast and the mammography is not that useful in our type of population. So a lot of things to ponder about, but what we can do right from the beginning, and to all who are there in your history, never omit this thing. Have any family member in your family have got cancer, be it a male or the female, in first and second relative, so that what were the protecting factor, what are the risk enhancing factor, so that we can utilize our resources, whether we want to do the genetic mutation or yearly transvaginal sonography to the population who is really at the risk. So great presentation, Dr. Lakshmi, and thank you very much.
Yeah, we shall quickly move on to the next Madhumita. So, Dr. Sadhana,
It will be by
Dr.
Dr.
Sadhana.
Lakshmi Ratnama.
Yeah. Dr. Sadhana, can you please
Yes.
introduce her? Yeah,
Yes.
yeah.
So Dr. Lakshmi Ratna Matkani, it is she has been senior consultant at Pune Hospital for Women and Children, Hyderabad, joint secretary of IMS, laparoscopic surgeon, and trained from ultrasound and colposcopy from UK. She is credentiated menopausal practitioner, so very apt person to give this talk. And she has graced many positions in Hyderabad Society as well as in the IMS. Pure reviewer of Midlife Health Journal, and she is first to start many programs in the state of Telangana, and has been awarded, bestowed many awards for her social and the academic work. So Dr. Lakshmi Ratnam, please.
Thank you.
Please share your screen. Please share your screen. Yeah.
I have actually shared. Again, I'll share.
Yeah. Yes, yes, it is happening. Can you make it a slideshow? Full screen? It was coming actually. Now we are seeing the full screen. You are seeing your
Yeah. Okay.
now it
Can
is.
you see?
Yeah, it is fine. Please go.
Yeah.
Yeah.
Thank you very much. Thank you very much for the entire Foxy and ICOG, all the executive committee, especially Dr. Shobha Gudi, who has invited me. Thank you very much to share my views on a premature menopause. Such a lovely program for the teaching ICOG certification course. Hearty congratulations. Now let us see what is about premature menopause. As defined most commonly as amenorrhea due to premature ovarian failure before the age of 40 years, spontaneous menopause occurring 2 standard deviations in years before the mean menopausal age of the study population. So it is marked by amenorrhea, elevated gonadotrophin levels, and estrogen deficiency. If you look at this, ovarian follicle depletion leads to decreased ovarian function, reduced estrogens. This is a natural decline of ovarian reserve and natural decline of hormone production in around age of 46 to 50 years. So the European Society for Human Reproduction and Embryology laid the foundation criteria for premature ovarian insufficiency as an oligomenorrhea or amenorrhea for at least 4 months and an elevated FSH level. More than 25 international units per liter on 2 occasions, then with 4 weeks apart. So premature menopause affects 1% of women under the age of 40, 0.1% in less than 30 years, and 0.01% in less than 20 years age. So these women, why are we worried? Because they are at risk of premature death, neurological diseases, psychosexual dysfunction, mood disorders, osteoporosis, ischemic heart disease, and infertility. There is need to use certain protocols. So the diagnosis should always be considered in any woman presenting with a history of primary or secondary amenorrhea or oligomenorrhea or vasomotor disturbances or other signs of estrogen deficiency and may be confirmed. So the incidence is seen in 10 to 28% of primary amenorrhea and 4 to 18% of secondary amenorrhea. Now, clinical status, there are something like a normal, occult, biochemical, and overt menopause. So in occult cases, what happens is serum FSH is normal, fertility is reduced, menses are regular. Biochemical, yes, FSH is elevated and fertility is reduced, still menses are regular. In a overt premature menopause, elevated FSH, reduced fertility, and irregular or absent menses happens. So the causes for this failure are unknown. Mostly 70 to 90% are idiopathic. A definite etiology was identified only in 11.8% of women. It can be a follicle dysfunction or a follicle depletion. So this needs to be really enlightened to the public and we should make it aware for the people. So premature menopause can be spontaneous or induced. Induced premature menopause could be as a result of medical interventions, chemotherapy, surgical interventions, or maybe due to autoimmune disorders, genetic causes, infections, enzyme deficiencies, or metabolic syndromes. Regardless of cause, women who experience estrogen deficiency at an early age before the natural menopause age are recognized to be at increased risk for premature morbidity and mortality. Now, if I look at the etiology, spontaneous, we have got idiopathic, genetic causes, autoimmune causes, infections. In induced, we have the surgery, chemotherapy, radiation, environmental toxins, and embolizations. So if you see the genetic disorder, the most common examples are, we know, all of us know that Turner's ovarian dysgenesis is the major cause. Especially chromosomal abnormalities are reported in 10 to 20% of the cases involving sex chromosome. Metabolic, we know certain enzyme deficiency, galactosemia, these were cause for the premature menopause. There are certain conditions in the immunologic, Dejav's syndrome, ataxia, musculocutaneous fungal infections. Autoimmune diseases, this is reported about in 30 to 60% of the cases. They are the more common causes in the later onset presentations. So autoimmune causes of premature menopause are thyroid disease, mumps, hyperthyroidism, Addison's disease. The ovarian biopsy or the adrenal biopsy, in this condition, they show infiltration of the follicles with plasma cells and lymphocytes. So women with autoimmune premature menopause are at increased risk for adrenal insufficiency, hypothyroidism, diabetes mellitus, myasthenia gravis, rheumatoid arthritis, systemic lupus. Infections, mumps is the commonest infection associated with the premature menopause. Its effect is maximal during the fetal and pubertal periods, when even a subclinical infection can result in ovarian failure. Pelvic tuberculosis can cause secondary amenorrhea. Mostly it can be due to also only end channel problem because of intrauterine syncytia. Now, smoking is known to induce premature menopause. There is a dose-related effect of smoking on age. The effect is believed to be caused through polycyclic hydrocarbons contained in the cigarette smoke. And coming to the iatrogenic, radiation and chemotherapy can cause premature menopause, but the effect is reversible and the ovary may resume ovulation and menstruation after 1 year of amenorrhea. Mega voltage radiation like 4,500 to 5,000 rats is associated with ovarian failure, but a radiation less than 500 rats restores normal ovarian function by 50% after a period of 1 year or 2. And pregnancies are also reported. So there is no evidence that low dose radiation causes. Or sometimes people think of ultraviolet light or a microwave, domestic microwave appliance, but they do not cause. The chemotherapeutic agents mostly are the alkylating agents, methotrexates, actromycin, adriamycin, and ovarian damage from cancer therapy depends on the age again at the treatment and on the type of the treatment. Women that are younger than 40 years are at a lower risk for ovarian failure. However, exposure to higher doses can cause damage. Even a prolonged GnRH therapy may lead to ovarian suppression and failure. Coming to the surgery, as all of us know, there was a period where ovary removal were very common along with the hysterectomy. So its surgery effort must be made to preserve all normal ovarian tissue and prevent damage to the ovarian blood supply. We have to counsel the patient. People think that anyhow both will go and there will not be any problem later on, and asking for ovarian removal, we should insist that they are very, very useful even after the 50 years age. Coming to the symptoms, menopause is associated with multiple symptoms such as the vasomotor symptoms, vaginal symptoms, urinary symptoms, and other symptoms like headache, depression, anxiety, irritability, skin changes, joint pains, cancer phobia, pseudocyesis, and lack of concentration. So all these will happen in this premature young ladies. Hot flushes occur in 75% of the cases and tend to be more severe than in a natural menopause, and they are the most common and distressing complaint. Their unpredictable in onset may present with recurrent periods of sudden, explosive, overwhelming, uncomfortable sensation of intense heat, flushing, beginning on the face and going up to the upper chest. May be associated with palpitations, a feeling of anxiety, and red blotching on the skin. Hot flushes last for 2 to 5 minutes, varying in frequency, with some women experiencing episodes of multiple times in a single day. Okay, and then urogenital system, we know that there is a loss of vaginal rugae, shortening, narrowing of the vagina, loss of mucosal elasticity, secretions, moisture, and this reduced vaginal secretion because of the lack of estrogen deficiency, lack of glycogen production, changes in the microbiome. All these causes more of vaginal infections and urinary infections. Diagnostic criteria, there are no unique clinical features that establish the diagnosis of a premature menopause. It is based on a triad of amenorrhea, elevated gonadotrophin levels, and signs and symptoms of estrogen deficiency. Because of the intermittent presentation of the disease, repeated assays may be required at intervals of 2 to 4 weeks. So women with FSH levels above 40 milli-international unit per ml may not have viable ovarian follicles on biopsy, and such a woman may be regarded as having undergone a permanent ovarian failure. The diagnostic investigations, of course, we must do a pregnancy test and exclude the possibility, and then FSH and estradiol. Anti-Mullerian hormone, which will assess ovarian reserve. These are the young individuals who may be looking forward for a pregnancy. And karyotype, Fragile X, mental retardation, FMR1 permutation, TSH, thyroid antibodies, and 21 hydroxylase antibody tests. Radiological test depends on the hormones and the need. Of course, transvaginal ultrasound, DEXA scan, as the condition is demands. FSH level more than 40, estradiol level less than 20 picograms are significant. Chromosomal study, sex chromosomal analysis should be performed on all patients who present with the primary amenorrhea or with early onset ovarian failure. Buccal smear should be avoided as X and Y chromatin tests are often unreliable for diagnosing sex chromosome abnormalities. AMH values denote ovarian reserve. Thyroid function, the woman who present with a later onset ovarian failure should be screened for high titers of anti-adrenal, anti-thyroid antibodies to rule out autoimmune adrenal or thyroid failure, which may follow ovarian failure a year or more later. Of course, blood sugars, blood calcium levels, bone mineral density studies are also useful. How does one manage an early menopause? The three critical issues of management in these women are the effect of the diagnosis on the psychological health of the woman, consequent infertility, and the long and short-term effects of estrogen deficiency arising from ovarian decline. So you have to see that the lifestyle modification must be there, like a healthy diet, regular exercise, positive attitude to life, engaging in a hobby, work of choice, housework, or a community work, non-smoking, minimal alcohol consumption, vitamins and antioxidants. Depending on the case, hormonal therapy and complementary and alternative therapies have to be discussed, counseled on an individual basis. Indications for MHT in these cases: premature menopause, vasomotor symptoms, yes, it is indicated. Genitourinary symptoms, yes, both systemic and local estrogens. Bone health, yes, estrogen replacement is recommended to maintain bone health and prevent osteoporosis. It is plausible that it will reduce the risk of fracture. Cardiovascular health, MHT with early initiation is strongly recommended to control future risk of CV disease. It should be continued at least until the average age of natural menopause. Sexual function, yes, adequate estrogen replacement is regarded as a starting point for a normalizing sexual function. Local estrogen may be required to treat dyspareunia. Life expectancy, we have to, it appears to be reduced because of the cardiovascular mortality. So it can, indirectly, it can affect the quality of life. Definitely, actually, it improves. Now, short-term consequences include vasomotor symptoms such as hot flushes, night sweats, palpitation, and headaches, weight gain, vaginal dryness, and dyspareunia, urgency and stress incontinence with the psychological problems including irritability, forgetfulness, insomnia. The long-term consequences of the premature menopause include fertility issues, osteoporosis, and an increased risk of premature death, cardiovascular diseases, and stroke. So what is osteoporosis? There is a systemic skeletal disorder characterized by low bone mass and microarchitectural deterioration. So women with this premature menopause are at increased risk for low bone density, earlier onset osteoporosis, and fractures. So estrogen deficiency as a result of declining ovarian activity have been implicated in this etiology. And cardiovascular consequences are also, because it's also associated with, estrogen is a cardioprotective in prevention of cardiovascular disease. It increases HDL and decreases LDL, cholesterol and triglyceride. And the estrogen receptors have been found throughout the cardiovascular system. A typical estrogen effect is a relaxation in the arterial tone and a decrease in the resistance. That is, which is very useful for the cardiovascular problems. MHT and cardiovascular disease. Women with premature ovarian insufficiency, regardless of the etiology, they have an increased risk of CVS problems, ischemic strokes. Compared with age-matched normal women, women with POI have reduced vascular endothelial function, which is an early sign of atherosclerosis. So treatment with use of HRT for 6 months significantly improves the endothelial function in these women. And timing hypothesis, we all know that MHT started early in the menopause definitely benefits us. Infertility. Fertility issues, women with POF, they have a 5% chance of spontaneous conception at some time after diagnosis. Several medical therapies have been tried to induce ovulation in women with these conditions. However, a systematic review, all were reported to be equally ineffective. Assisted conception with a donor oocytes has been used to achieve pregnancy in women, and presently it remains the only means of fertility treatment that carries a high success rate in this premature menopause. Now, spontaneous pregnancies from an idiopathic premature ovarian insufficiency, they do not show any higher obstetric morbidity or neonatal risk as compared with the general population. And due to genetic causes, they should undergo a preconception counseling to better understand the risk to their progeny and of a miscarriage in the event that successful conception is achieved. Based on risk assessment, many may choose to consider use of a donor egg to maximize their chances for a healthy pregnancy. Those who are diagnosed with a Turner syndrome, they hold unique pregnancy risk due to the high rate of cardiac abnormalities seen in this population and pregnancy-related escalation in risk for catastrophic cardiovascular events such as aortic dissection. Evaluation by a perinatologist and a cardiologist are essential, given that any evidence of aortic root abnormalities common in this population is a contraindication to pregnancy. Male children of the women who harbor the FMR1 pre-mutation may be at an increased risk of being affected by Fragile X mental retardation. For women anticipating receiving pelvic radiation, where radiation-induced PVI is almost inevitable, surgical transposition of the ovaries out of the pelvis can limit radiation exposure and may serve to preserve gonadal function. For women anticipating chemotherapy with a gonadotoxic agents, other than the fertility preservation options of egg, embryo, or ovarian tissue cryopreservation, or suppression of ovarian function pre-chemotherapy with the use of a gonadotropin-releasing hormone, they are tried. Now, estrogen facilitates the actions of serotonin and norepinephrine. A decline in the estrogen concentrations may in turn decrease the levels of these hormones, causing depressive symptoms. For a major depression, standard antidepressants are the first line. For a mild depression, MHT alone may be appropriate. The diagnosis of PVI is most often unexpected.
Madam, sorry to interrupt you. Your time is up.
Okay. Frequent visits with the women's multidisciplinary team should be arranged to provide a continued observation of her coping about the strategy. Last two slides. Why are we worried so much about premature menopause? Women with this condition are at risk for low bone density, earlier onset osteoporosis, earlier onset coronary artery disease, increased mortality. They have been reported to have diminished general and sexual well-being and are less satisfied with their sexual lives. The more anxiety, depression, all these are. That's why we are more worried. It's a good practice to recommend estrogen replacement therapy for women with the premature menopause. And also, we have to do the correct diagnosis, educate the patient, symptom management, if required, fertility management, and preventive aspects for the CVDs. So these are the things which are recommended. So hormone therapy is the cornerstone in the prophylaxis and treatment of these bone conditions. However, there is a strong evidence that long-term risk and adverse health outcomes following induced menopause is increasing. So PVF incidence has increased over time because of the improved success in the treatment of cancers in children, adolescents, and the reproductive age women. So there is some evidence that restoring normal estrogen levels will reduce the later development of cardiovascular disease, osteoporosis, and possibly dementia. Treatment for each woman is considered virtually mandatory, and we should hope that this kind of a treatment with a good education, counseling will make them feel comfortable and they do not feel the depression. Thank you very much.
Thank you, Dr. Lakshmi. It's a very difficult topic, and we can say 2 or 3 lines if we can say sum up. One is we have to consider when we label any patient with any woman with a premature ovarian insufficiency, the age of menopause in that ethnic group is very important. And if it is -2 SD, then we say, because a lot of variation is there in the developed Western world and the our area. And as 48 is the India average age of menopausal transition, we take it around 41 to 42. So one thing is that ethnic variation when we label. Second, you have beautifully summed up all the cause analysis, what is there. And the thirdly, which I will like to emphasize, that whenever we are putting these women on the menopausal hormone therapy, we have to consider that they have contraceptive need or they have what are their reproductive need, because contraceptive need is not being fulfilled by the conventional MHT, and the right choice of the menopausal hormone therapy is very, very important. So thank you very much, Dr. Lakshmi. And we go ahead with our next very eminent speaker, Professor Ambuja Choraner. I consider Dr. Professor Ambuja as my mentor and who has been the president of the Indian Menopausal Society. She is retired professor and head of the department in Ismania Medical College, Hyderabad, visiting professor in Chennai, yes, president IMS, research committee chairperson of the SEFORMS and the faculty and resource person for the DNB examination, All India Vice President for Family Planning Association of India, and peer reviewer of many journal. And she is consultant editor for the JK Science Journal of Medical Education and Research. Very novel and very noble person. We look forward to listening to you and learn so many things from Professor Ambuja Choraner. Warm welcome.
Stop sharing the screen, then I think it's already I'm there.
Yes, ma'am. Can you share your screen, ma'am?
Yeah, I did. Yeah,
Yes, ma'am. You can share your screen.
Yeah. Good evening, everybody. Yeah. And thanks to ICOG team and Foxy for inviting me for today's special menopause special. And thanks to Shobha and Biniwala for the opportunity that is given. And today's topic, vasomotor symptoms, it looks very simple, but for the person who suffers, they know how difficult it is to bear with it. And implications of this is very important. Am I audible? Hello, am I audible?
Yes, ma'am. You're audible, ma'am. Yes.
Yes.
So, vasomotor symptoms is nothing but having hot flushes, night sweats, and general sweating in peri and early menopause. It's so simple to talk that it's only flushing that will be there, but it will be so distressing for people who suffer with it. Actually, in Indian context, what study we have done and published in 2012, almost 75.3% of the women had vasomotor symptoms. That is the first presenting symptom in the peri and postmenopausal women. In Western countries, of course, it is 80 to 85%, and more in the rural areas than in the urban areas. This is a sudden onset of heat generated in the upper chest, moves to the face all becomes red, and it lasts for 2 to 4 minutes, is often associated with profuse perspiration and occasionally palpitations, chills, shivering, and feeling of anxiety will be present. Usually less than one each day will be present. Sometimes it will be so severe, most of you would have experienced if it is there. Every 1 hour it will be there, and more during night. And it causes anxiety, sleeplessness, restlessness, and not only to you and to your partner also. Sudden decline in estrogen leads to vasomotor symptoms. Usually it will about 7 years, for 3 to 4 years before starting the menopause, and it extends about a year or two after the menopause. But in about 25% of the people, it lasts for 14 to 20 years also. There are short-term and long-term consequences. That's what is very important. Just having a hot flush is not going to, it is flushed away like that. But short-term consequences, sleep disturbances, anxiety, palpitations, mood swings, cognitive deficiencies, work-related difficulties, definitely it is more. Morning they will get up and they will not be able to work. Going to office is such a difficult problem. And health-related quality of impairment, quality of life impairment will be present. What about the long term? This is very, very important. Cardiometabolic risk. This is always we forget about this. These people, more heart pressures, more cardiac CVD problems will be present. And it all depends upon the intensity, number of heart flushes, and duration of the first starting heart flush. These are all the things that are very important. Always we say postmenopausal heart pressures. Absolutely not. It starts in the perimenopausal age, somewhere about 3 to 4 years before menopause, and then it extends on to the menopause. Why this heart pressure occurs is in the perimenopausal age group, there is the peaks and troughs of the estrogen that will be present. Mainly it is because of the estrogen deficiency, but why not it occurs in the person who is primary amenorrheic or Turner syndrome? That's what is the question always, because it is not the estrogen deficiency only, it is the estrogen withdrawal. Before, if the woman is exposed to estrogen, it is withdrawn from the body, that causes the heart pressures, and peaks will be present when it is in the perimenopausal age group, and it comes down later on when estrogen, it stabilizes to the estrogen. And always we think it is only the estrogen deficiency, but correlation between the estrogen levels and heart pressures, usually it will not go. And persistent VMS is present for a long time, at about 14 to 20 years. Always you think, rule out the secondary causes like hyperthyroidism, pheochromocytoma, infections such as tuberculosis, malignancies, and some of the certain drugs, beta blockers, if you are using nitrates and niacin, always you should exclude these conditions. WHO has classified vasomotor symptoms into mild, moderate, and severe. Mild is the one where sensation of heat without sweating, and moderate, a sensation of heat with sweating, but the ability to continue the activity normally. Severe is the one, sensation and sweating that causes the cessation of the activity. This usually happens in 80% of the people, but in 25% of the women who are called the super flushers, means heart pressures start very early, that is 5 to 10 years before menopause, and continue well into the post-menopause. This chunk of people are more prone for the cardiovascular diseases. There are certain risk factors already Lakshmi Ratna has told, like obesity, smoking, and reduced physical activity. But the triggers, so many foods, many times patients will come and ask, is there any food that I should avoid? Yes, certainly some processed food or spicy foods, white grains, and caffeine, beverages, these things they have to avoid to lessen the amount of heart pressures. A little bit about the pathophysiology, which is very essential before treating the patient. Heart pressures are mediated by the dysfunction at the level of the hypothalamus and are induced by the estrogen withdrawal. Means the thermoregulatory zone is reduced in the menopausal women, where the sensitization will be for this, it will be more. Even a little change in temperature produces the heart pressure. In the hypothalamus, it has got the estrogen, because of the estrogen deficiency, the sensory nerve endings that will be present for the thermoregulation, which are damaged, and because of the disruption, and it produces the 5-hydroxytryptamine and imbalance of the receptors which will be present, which leads to the altered thermoregulatory response leading to the heart pressures. Estrogen withdrawal alone does not explain the cause of menopausal vasomotor symptoms. This is evidenced by the observation that is no significant correlation between plasma hormone levels and occurrence of vasomotor symptoms. Because you see, after about 10 years of menopause, the estrogen level comes down to lower level. In 80% of the patient, there will not be any heart pressures. And there is something else which produces the heart pressures, which we deal with it. Estrogen withdrawal, therefore, it is necessary, but not sufficient to explain the occurrence of menopausal heart symptoms. This is a new development which we should understand. The K and Y neurons that are present in the hypothalamus, that is kisseprotein, neurokinin D, and dynorphin neurons that are present. These neurons located in the arcuate nucleus of the hypothalamus, where the thermoregulatory center is present, and this is the one which is highly innervated by the estrogen receptors. The estradiol withdrawal of the menopause transition results in the removal of the negative feedback of these neurons. Actually, the effect of these three neurons is acting on the GnRH, which increases the production of GnRH and pulsatility. That's what is very important in maintaining the reproductive cycles. When this negative feedback from the ovarian estradiol is absent, these neurons hypertrophy and so overactive and giving rise to more of stimulation to the GnRH and so produces more of FSH and LH, which is the reason to have the vasomotor symptoms in the premenopause. I think I made it clear. This is the Kisi protein, neurokinin B, and dynorphin neurons. They are called the KNDY neurons. That stimulation, because of the overstimulation and negative feedback is not there in the postmenopause, leads to these vasomotor symptoms. What are the long-term effects? I told you it is the metabolic risk is increases. Means, what is the metabolic syndrome that is there? The cardiovascular disease, diabetes mellitus, obesity. Central obesity is the main thing that happens, and non-alcoholic fatty liver disease. These are the contribution components of the metabolic syndrome. Presence of severity of the VMS is associated with increased risk of metabolic syndrome, insulin resistance, non-alcoholic fatty liver disease, and osteoporosis. VMS are biomarkers for impaired cardiovascular metabolic condition. Suppose a patient has got number of heart pressures and day and night and for a long period and starts at an early age, if it is present, it definitely says there is a impaired cardiometabolic. One thing we know, because of the cardiac problems, the death in the menopause is more. Mortality after menopause steeply increases compared to the men. It is because of the cardiovascular disease that occurs because of the vasomotor symptoms. That is why it is a marker for the thing. So altered lipid profile will be there. That is visceral obesity. HDL is decreased. This is a good cholesterol which is decreased, and insulin resistance and high triglycerides and hypertension. These five are the major the things that will happen because of the we have observed in with the heart pressures. Previously, what we were thinking is the obese people are spared; they don't get the vasomotor symptoms. It is wrong. We were thinking that because of the fat that is present, aromatization of the fat that leads to the estrogen, so heart pressures will be less. Now it is clarified. The fat produces inflammation, so there is increased vasomotor symptoms, and they are both prone for the metabolic syndrome. The SWAN study, which is the largest study after the WHA, of course, randomization is done. It showed that frequently the more of heart pressures are related with the decreased HDL and increased other parameters of the lipid profile. Night sweat is associated with more of metabolic syndrome. What happens to this? A Korean study, a prospective cohort study was done in women with between 40 to 50 years, demonstrated that women with frequent vasomotor symptoms were increased risk of developing coronary heart disease over 14 years of age. Means immediately they may not get it, but they will have the problem for 14 years of age. Adjustment for the age, menopause status, and lifestyles and chronic diseases are excluded. What we should understand is there is something like the subclinical CVD risk that is present. These are the people, we can identify them at this stage and we can treat them. How do we identify that subclinical cardiovascular disease is doing intima media thickening for the carotid arteries. It is very easy. It's the ultrasound examination. It is not an invasive procedure. With this, we can make out how much of the calcium that is present. That is why, depending upon that early start of the treatment, whether it is a hormonal or non-hormonal, which reduces the cardiovascular risk for the patient. So sympathetic, this leads to the sympathetic activation, altered vascular function, and leads to the hypertension. So, and leads to the aortic calcification. These two things, if we can do it, one is intima media thickening and aortic calcification. These are the markers which we can say that the prevention of the cardiovascular disease is possible. And these people are non-alcoholic fatty liver also is more compared to the other people. And it is done a study where people having the vasomotor symptoms and not having the vasomotor symptoms, when they have studied, this non-alcoholic fatty liver is more compared to the other people. And management aspect, if you come, many people, they don't seek. This is what is the Indian study showed, and unaware of the treatment, 70% of the people, they are not aware of the treatment. We have
Ma'am, your time is up.
Yes, two more
Yeah.
slides, please.
Yes, ma'am.
And non-hormonal medications and hormonal therapy is there. Hormone therapy already Lakshmi Ratna has covered. I am not going to deal with. Only thing is, we should see is the patient candidate for menopausal hormone therapy, personal choice, and coexistence of the other menopausal symptoms depending upon the. Before starting the treatment, we have to do the examination and see for the risk of cancer risk. Cardiovascular risk assessment has to be done. Depending upon that, hormone should be given. So, holistic management is necessary. Mild heart pressure, simple lifestyle changes, moderate to severe and no risk factors, low dose estrogen plus progestin therapy. Moderate to severe heart pressures will give the either non-hormonal where she's not fit or she doesn't want to take hormones. No, SNRI and SSRIs can be given. For women with predominantly night sweats, it is the gabapentin is good because it produces little sedation also. So this is the latest drug that has come out. I think we should know non-hormonal treatment. There's a fizolinintat. This is a FDA approved drug when estrogens are contraindicated, and fizolinintat can be used. It's a moderate to severe heart pressures, and it is taken orally 45 milligrams per day. What is this drug? NK3, that is what is the neurokine I told you, that is the hormonal neurons that are present in the hypothalamus, the receptor antagonist, and so it regulates the body temperature. Only thing is, when we are giving this, the LFT should be done every 3, 6, and 9 months to see that it is a thing. So this hypertrophy and hyperproduction of these neurokine hormones, it prevents it. That is how the heart pressures are prevented. It is the first in class non-hormonal neurokine receptor antagonist, and it doesn't help with the vaginal symptoms of menopause because it blocks the chemical in the brain that plays a role in the body temperature regulation. Side effects, already I told you, it is the liver damage can occur, so you should be very careful. And upcoming drugs, the new innovations are there. One is about the intravaginal ring that is coming, which can be used once in 28 days, and rapid onset nasal spray for VMS and migraine also, it is coming up. The non-hormonal agents, there are SSRI and SNRI are present, and gold standard best treatment is the estrogens for relief of vasomotor symptoms. Any type of estrogen reduces the vasomotor symptoms, but only thing is we don't want to use ethinyl estradiol or only natural estrogens. That is the estradiol, 17-beta estradiol is the best to use. Even we stopped using the conjugated equine, whereas but any type of estrogen, it reduces the vasomotor symptoms. So it is whenever the uterus is present, you should use the progesterones to prevent endometrial hyperplasia or carcinoma, because the unopposed estrogen, even if it is used for 6 months, it is shown that they produces the endometrial hyperplasia. So, and transdermal estrogens are less likely to produce complications like venous thromboembolism, stroke, and CAT. Actually, the International Menopause Society suggests no oral 17 beta estradiol. We have to give for everybody transdermal, but for us, the cost is a factor which we don't use the transdermal. How long? Usually we use it for 12 months. Stop it. If the symptoms recur, again you stop and useful. And whenever the symptoms comes down, you can stop the hormones. So what is the outcome? Which one is the best we should see when you are giving hormone therapy? 90% reduction will be present. Venlafaxine 60 to 75%, gabapentin 50 to 60%, and vitamin E, soy, and all is present, but it's like a placebo only. They are 25%. They are not FDA approved, either soy proteins or isoflavones, vitamins. They are not approved by the FDA. So, final comment is vasomotor symptoms should not be taken lightly. Cardiovascular disease implications depends on severity, duration, and time of onset of the vasomotor symptoms. 17 beta estradiol is the gold standard in treating vasomotor symptoms. Transdermal is preferable. Non-hormonal is option if hormones are contraindicated. Fezolinetant, that is the NK3 receptor agonist, is novel non-hormonal option for moderate to severe vasomotor symptoms. So thank you for patient listening and thanks for giving the opportunity.
Thank you so much, ma'am. Dr. Sadhana Gupta, ma'am, will be giving the concluding remarks now. Yes,
Thank you, madam. Thank you. And I will like to have one or two questions about you. What you said that majority of the women does not seek treatment in Indian setting. One, like my experiences, sometimes they seek the like a treatment from the cardiologist because of not anxiety, and we come with all ECG and echo, and sometimes to the psychiatrist as well. So your comment about that awareness for the hot flushes and the family and the support from their workplace, that makes the thing very, very complicated, and they are having all tranquilizer and something. And the second thing, that this Fajolet, the new drug, is it available in market, or is it available for in India? And what phase,
Two things,
the
madam.
drug is in which phase? So
definitely counseling has to be given to the family members and workspace also, because it is a very difficult, tough time for anybody to tell, because they always previously used to tell you have become more psychological, but now people are understanding. Definitely counseling to the husband is essential. What about the Fezolinetant is not available right now in India. It is available in other countries, but it is still stage 3 trial is going on, and of course it is FDA approved, and it is a very good. Cost is very high. Maybe in future we'll get it in India.
So it is in phase 2 trial. Still, it is in phase 2 trial.
Stage 3 trial.
Phase 3.
And I mentioned it because in future it may be the choice compared to estrogens, because many people are not preferring hormones. That time we should know that such a thing is available, where it is non-hormonal and the complications are less, except for the liver problem. Once we give importance to that one and check liver functions frequently, then maybe in future it is a first line treatment.
One last question before we say, with your immense experience in the Menopause Society, that Dr. Lakshmi said, and you said that yes, it is related to premature ovarian insufficiency, premature mortality, and you said that it is like a surrogate marker for the cardiovascular disease. To me, like in South Asia, as it is what the paper says, the women take a more positive approach towards menopause as compared to Western world. How we should be very careful about counseling, that yes, we know it is related to premature mortality or premature cardiovascular cerebrovascular disease. Your tip to everyone who is joined for the certification course, how we can make this counseling very positive and not frightening, especially in that age when the real sickness and old age is a real thing, it is not something imaginary. So your last comment about this.
Yes, Sadhana, this is a very good question. I'll tell you, we should counsel them. The next speakers are going to tell about the diet and exercise. Everybody should have diet and exercise to prevent these complications. And in advance, they should know that this is possible. That is, cardiovascular disease is the major cause of mortality in the postmenopausal women. And maybe in future, we all should get in the perimenopausal stage itself, we should get the carotid artery intima media thickening. Of course, about the metabolic syndrome, lipid profile, yearly lipid profile, what Maninder is suggesting, and the way maintain the body weight. These things are very, very important to prevent a metabolic syndrome, which is a major cause for the metabolic problems that can occur in the women. That is how we can counsel them about the diet and exercise. And I showed you what are the triggers for the metabolic syndrome, better to avoid all those things. And then counseling the women that they are prone like men for cardiovascular disease, we should tell them. So any small problem they get, they should approach the doctor and get the investigations done. Especially this regularly we are doing nowadays the carotid artery intima media technique for many people, because it is a non-invasive and it is ultrasound. It's not taking much time and money also. So that is the best thing what we can advise them to have regularly.
Yeah. Thank you, ma'am. This was a very good indeed point you pointed out. Let us proceed, Dr. Archana, you're conducting the second session. Thank you, Sadhana, ma'am, for chairing it and giving your valuable points. And Ambuja, madam, has given us insight of some few drugs which we really look forward to have in India soon. So over to Madhumita and Archana.
So after this highly informative session 1, we move on to session 2, which will be containing 3 lectures. Overactive bladder by Dr. Neeta Thakre, Lifestyle Management by Dr. Neeraj Chawla, and Exercise in Menopause by Dr. Maninder Ahuja. This will be chaired by Dr. Vinita Singh and Dr. Rakhi Singh. Dr. Vinita Singh, she is Associate Professor, Department of Obs and Gynae, NIMCH Patna, and Consultant Cardio Hospital and IVF Center. She is East Zone Coordinator, Foxy. Dr. Rakhi Dhawan Singh, she is President NOGS and Vice Chairperson of UP State Chapter ISR, Peer River of Journal of Obs and Gynae of India. She has been Chairperson of Endocrinology Committee, Foxy 2020 to 2023. So I would ask Vinita ma'am to please introduce the first speaker of this session, Dr. Neeta Thakre.
Hello.
Yes, ma'am. Vinita ma'am, are you there?
Yeah, I'm there. Vinita, I don't see there. Is she there? Rakhi is there.
She had requested to take.
Yeah, we are there. I think we were in first speakers. Nirja is there.
Ma'am, I had requested because I have something to attend to. So
Okay.
I'm
in Australia. It's already 11:30 p.m.
Let me know whom to introduce then. Who wants it?
It's okay. It's okay. I'm always sporty.
Thank you,
ma'am.
Maninder. Thank you, ma'am. I would like to introduce Dr. Neeta Thakre. She is the Honorary Secretary of Ahmedabad Obs Gynae Society.
and she's been very active in Foxy also, and she has lot many what do we call academics at peak, and lot many we know her as a very good friend and a good human being. She's got many accolades to her credit also.
Thank you so much, Rakhi. Thank you for that kind introduction. First of all, I would like to thank the organizers for inviting me and sharing my thoughts on the subject that is close to my heart, which is incontinence in general or urinary issues. And I think overactive bladder plays a very important role in a woman's life. It's a major issue post-menopausally, and today we are going to discuss about the same. I think Dr. Archana was going to share my screen, my presentation on screen. So, Dr. Archana, are you there?
I'm the tech will team will share your screen.
Yeah, I'm sharing the screen.
Yes, ma'am.
Okay. So I'm waiting for the same. So can we do the slideshow? Full screen? Yeah. So what is overactive bladder? Let us start from its definition. International Continence Society has defined it as urgency with or without urge incontinence, usually with frequency and nocturia. Next. Can we change the slide as well? Yeah, next. Next, man. Who is changing? Yeah. So the definition, according to definition, there is frequency, urgency, and nocturia, but which may convert into incontinence or may not. And what is detrusor overactive? It is a urodynamic diagnosis of the condition in which ACH-induced stimulation of muscarinic receptor occurs. So not all the overactive bladder patients will have detrusor overactivity, and not all the detrusor overactivity patient will have overactive bladder. So this is the difference between the two. Now next, what is the pathophysiology? When the contraction, which is inappropriate, starts occurring during the filling phase of maturation. So bladder is partially filled and still the detrusor muscle starts contracting. Next. Yeah, so what are the symptoms? Symptoms are urinary urgency, frequency more than 8 in a day and more than 1 at night. So she gets up twice at least, and with or without urgency incontinence. And you have to be very specific when it comes to this definition. There is no bladder pathology involved. So almost 20% of our population is going to have it sometimes in the life. Next. There are two types. One is OAB wet and one is OAB dry. When it is without incontinence, it is dry, and with incontinence, it is wet. Next. So what are the etiological factors? It can be idiopathic, it can be psychosomatic, it can be following some surgery, mainly incontinence surgery, and sometimes it is neurogenic in the cases of multiple sclerosis, diabetic neuropathy, spinal injury, Parkinsonism, etc. Today only I got one patient who is only 19 years old and she is continuously leaking and having pads for almost 2 years by now. And we are going to investigate her, but it can be the age it can be so variable. So what is OAB? OAB is fun. Why? Next. Because it has the symptoms of frequency, urgency, nocturia, and nocturnal enuresis. And what you see, vulval excoriation, urogenital atrophy, residual urine, which is more in amount sometimes, and stress incontinence, which can be associated with it. Next. So urgency key symptoms are increase in the frequency, reduce in the volume because she goes frequently. So the volume voided is not good enough and it may be very small in amount. Urgency incontinence can or cannot be there, may or may not be there, and nocturia. Next. So it affects both male and female. It's not only for female. Next, but it is more common in female, that you can see from the chart. Next. So healthy bladder versus bladder which is having overactivity. Next. Madam, yeah. So if what is healthy bladder? Healthy bladder holds at least 300 to 500 cc and it empties less than 8 times in a day, and one can hold at night, and after gradual filling, urge is felt. On the other side, when it is an overactive bladder, it empties more than 8 times per day, it empties more than twice per night, and it has urgency, that is sudden compelling desire to void, that is difficult to control. Next. Next. Hello. Yeah. So what is the negative impact on the quality of life? Patients have psychological impact. They suffer from depression or guilt. The occupation is also affected because they are less productive. Physical limitations are there. Socially, they avoid going out, being in party, because they always search for toilets, and at times their sexual life is also affected. Next. So how to diagnose? We have to take proper history, and there is one QOL questionnaire, quality of life questionnaire, and also urgency severity scale. And you have to do proper physical examination, pelvic examination. You must do it first with full bladder, do stress test, do Q-tip test if you are academically inclined to. Otherwise, it can be avoided. You watch for cystocele, levator ani muscle, and sphincter, anal sphincter tone. And simple tests like voiding diary, urine analysis, post-void residue on sonography, cuff stress test, and PET test is done. Next. Advanced testing like urodynamic, uroflowmetry, filling cystometry, urethral pressure profile, leak point pressure, and voiding cystogram is done only in few cases, not in all. When it is complicated, you must do it. Otherwise, it can be avoided. And imaging tests like sonography, fluoroscopy, functional neuroimaging, and MRI can also be done according to the case requirement. Advanced testing like neurophysiological test, in which pudendal nerve terminal motor latency is seen, sacral reflexes are seen, somatosensory evoked potential is seen, and EMG and PET scan also is advised in few cases. Next. Role of urodynamic study is very typical because you want to find out underlying pathophysiology, and it can be helped by directing the treatment. What is the urodynamic study that tells us how to treat the patient? Next. Next. So the treatment options are conservative treatment, pharmacological treatment, and procedures like InterStim and Botox. So what are the conservative treatments? It consists of bladder retraining, biofeedback, behavioral modification, fluid management, pelvic floor exercises, etc. So next slide, please. So general measures like psychotherapy, these patients do require psychotherapy at times because they are having psychosomatic problems and other medical conditions as well. So you have to, listen to them, talk to them very carefully, very, in a caring manner. And the psychotherapy also helps them quite a bit. Otherwise, behavioral therapy includes limited fluid intake. This is very, very important because most of our patients, what we have seen is these days they drink at least 2.5, 3 liter, 4 liters of fluid per day. Those patients who are already having overactive bladder, if they are given this much amount of fluid, or if they take this much amount of fluid because of any hearsay, then they are going to face the issues more. So you have to guide them about the intake of fluid, which should be restricted to maximum 1.5 liters per day. Tell them to reduce tea, coffee, alcohol, which are the bladder stimulants. Very spicy food, chocolate should be avoided. Diuretics, if at all they are on, should be stopped, or any other alternative method should be found out. Weight loss helps them quite a bit. Bladder retraining in the form of bladder drill and biofeedback, as well as hypnotherapy, helps them a lot. And almost 83% are asymptomatic by the end of 6 months. But let me tell you, when you stop it, it really relapses very quickly. So you have to tell them that if they are on behavioral therapy and if they are benefited, they must continue doing it. Next. So this is the first line of the treatment, which is behavioral therapy, in which you have to educate them. You have to tell them to form a chart or a diary, bladder diary. Bladder food, bladder diet is to be advised. As I told you, it should be devoid of stimulants, and that will help them a lot. Today, the patient I told you, she was telling that when she takes coffee, she has more symptoms. So it was her observation that my coffee, worsens my symptoms. So that we have to help them to identify those stimulants and avoid them. Advise them to time void, because most of the time we have seen that female avoid voiding at the first call. So they have to attend to their first call, so that to avoid overactive symptoms or an accident in the form of incontinence. Pelvic floor exercise with or without biofeedback makes a lot of difference, and that should be advised. And they gradually should train the bladder by increasing the gap between two voiding episodes. So if they initially were voiding every 1 hour, then gradually the voiding can be advised after 1.5 hours, or then 2 hours. So gradually bladder has to be trained. So clinical effects, what happens when these measures are taken? It stabilizes the muscle, detrusor muscle, bladder capacity is increased, and there is frequency of involuntary bladder contraction, which decreases and delay initial urge to void. So they gradually try to understand. I tell my patient to count from 100 to 0. So their mind is diverted, and that's how it is helped. Lifestyle interventions and bladder training. Lifestyle interventions like, done for more than 6 weeks should offer as a first line treatment, and weight loss also makes hell lot of difference. Tolterodine and bladder therapy appears to improve the outcome over drugs alone. So it has to be advised as well. Next. So antimuscarinic, now coming to pharmacological aspects of this problem. Antimuscarinic drugs are the first line of treatment, and it is very effective in many patients, but it has got side effects like dryness of mouth. And that is where the patients are not, they discontinue the therapy very frequently. Next. What are the antimuscarinic agents? Anticholinergic agents are derifenacin in the form of 7.5 to 10 milligram OD, oxybutynin 5 milligram TDS, solifenacin 5 to 10 milligram OD, tolterodine 4 milligram OD, trospium 20 milligram BD. And these preparations are come in the form of immediate release, extended release, and transdermal. Not in India, transdermal is not available. And all these, what does it do? It may cause urinary retention sometimes. So you have to be very watchful. Tell the patient, if she feels that their bladder is not getting emptied, she has to report. Or whenever she comes for follow-up, please check post-void residual urine. Next. These are the anti-muscarinic agents like oxybutylene, tolterodine, salifenacin, imipramine, and DDAVP. So these are the drugs. This chart is very helpful to know about the side effects and cautions that you have to take care of during prescribing this therapy. Next. These are the contraindications, mainly urinary retention. If patient is having pregnancy, you should avoid hypersensitivity to drug, of course, and uncontrolled narrow angle glaucoma. We have to first rule out. And you have to take precaution when there is a significant bladder outlet obstruction, decreased GI motility, when there is a controlled narrow angle glaucoma, and hepatic impairment. Next. The new drug on the, in this parametrium is B3 agonist, that is selective beta-3 adrenoreceptor agonist. What it does, it relaxes the bladder muscles and it increases the bladder capacity, and that is how it helps. So it is recommended. I will take 1 more minute. It is recommended when there is an antimuscarinic agent not working or it is contraindicated, and it is if it is unacceptable, having unacceptable side effects. Next. And its mechanism of action, as I have already told, is it relaxes the detrusor smooth muscles and it improves the storage capacity. Next. So, what is refractory overactive bladder? When the bladder or treatment fails to respond to 2 anticholinergics given at least for 15 days each, and in those cases, please do urine cytology to rule out malignancy, bladder malignancy, urodynamics, cystoscopy with cystodistension can be advised. Next. This is another method where you are doing percutaneous tibial method, tibial nerve stimulation, and it is a type of neuromodulation system which can be done in office. Next. Botox, it has got wonderful effect to treat overactive bladder, and Botox has those who is very useful or helpful in patients who cannot tolerate the side effects of the medicines. Next. Elargan Botox is given in the dose of 100 units. Next. It is given in the dose of 100 units, and it is bladder, in the bladder, it is injected by a small needle at almost 100 sites, and the whole bladder is covered, which will reduce the frequency, urgency, and nocturia. And there is a significant improvement of quality of life. And only thing is you have to watch for retention, and high rates of UTI also is seen. So you have to take care of that. Next. SNS therapy, and that is also very sacral nerve stimulation, which is very, very important in done in 2. One is cutaneous and another one is permanent. Next. So phase 1, where there is a test stimulation, you give this therapy by a temporary lead, but when patients are benefited, you can give in a second stage chronic lead, and it is a surgery which is little complicated. I don't know anyone, someone is doing in Mumbai, but not in Ahmedabad. Next. Next. So it is called interstitial. Next. And radiological guidance, under radiological
Sorry to
guidance.
interrupt, ma'am. We are overshooting the
Last
time.
slide. This is the last slide. Surgical aspect of this treatment. It includes denervation, augmentation clamp cystoplasty, urinary diversion, that is in ileal conduit. The ureters are, diverted to ileum, and that is how the continence is achieved. And detrusor myectomy rather. And the recent development includes SOLA background, which is also given in irritable bowel syndrome, and it produces visceral analgesia by releasing somatostatin and adipocytes. So I think this covers the whole lot of treatment options. Thank you, organizers, for giving me this opportunity and sharing the thoughts. Thank you so much.
Thank you, ma'am, for the wonderful talk. Chairpersons, please comment.
I think
Rakhi, ma'am.
Rakhi, I saw she's driving. Maybe it's not good for her to just now get distracted.
So I
Vinita
think
ma'am,
Maninder ma'am can take the comments, concluding comments, if Maninder ma'am is here, and then we can shift.
Yeah. She's driving, I suppose.
Or Vidya Thobi ma'am, anybody
So-
can give a concluding remark. Maninder ma'am, can you do that?
So,
okay, so I think we'll invite Dr. Neerja ma'am for her talk. And
Yeah, I think overactive bladder is a very, very important part as far as the women's life cycle is concerned. But we are here talking about the menopause basically. So menopause basically can cause because of the estrogen deficiency also, where the urgency can be there. So we have to look into that problem also in these women. So we have to exclude that problem
Rakhi
also.
has written that she is muted. Can you unmute her? She wants to talk, I suppose.
And Dr. Neeta Thakre, congratulations,
Thank
you have come.
I think.
Thank you, Neeta. It was a wonderful talk. I was all through for your lecture also. I have got one doubt, Neeta ma'am. The only thing is nowadays there's lot of this overactive bladder. They are propagating those chairs, which is cosmetic chairs, which are coming up, which they claim that it works very well for that overactive bladder. I would like you to just give a few comments on that.
See, those chairs will stimulate the pelvic floor muscles and it will act as a pelvic floor muscle exercise. So it is, of course, a good method of conservative treatment. And it will work only for those who are having mild to moderate symptoms and not moderate to severe symptoms. So you can offer the patient these treatments, especially in those if they are having it post delivery, or but if they are having it post any incontinence surgery, it is not going to play any role in that. So you have to select a specific patient depending on her symptoms and her severity of symptoms, and that's how they can be benefited. Not all the patients are benefited.
Yeah, and a little heavy on the pocket as well. So let's proceed further, ma'am.
Thank you, Neeta.
Thank you.
Thank you.
Rakhi ma'am, please introduce Dr. Neeta Chawla, ma'am.
She's driving.
I'm driving. I'll not be able
No, it's
to
okay,
read up.
ma'am. Just continue. I'll invite Dr. Neerja Chawla, madam, for her talk. We're looking forward. She is, I know, you can see her background, a yogi sadhana person, but a very intellectual person and very dear to us as IMS family as well. She's director, gynec infertility and minimum access surgery. Passion for pioneer endoscopy surgery is there. I think we would not like to stand in between your talk and myself. So over to you, Neerja ma'am. We are eager to listen to you. Kindly share the slides.
Yeah, I'll just do that.
And I would like to thank Nirja ma'am and Malinder ma'am for understanding and giving me the previous time earlier than what I was allotted. Thank you.
You're most welcome, Neeta.
Thank you.
So, hi everyone. Good evening. So, I wish to convey my thanks to Shobha for inviting me here, and my warm regards to the office bearers of Foxy, ICOG, and the chairpersons. So, let me just begin. And vasomotor symptoms, of course, Ambuja has dealt with. Now, the question that we are asking is why lifestyle modifications? I think all the previous talks that we have had, cancers and overactive bladders, they have added to why we need vasomotor symptoms and management of lifestyle. And we have compelling data about a lot of things: obesity, Met syndrome, their complications, the atherosclerosis, MI, stroke, kidney damage, cancers, degenerative brain diseases, cognitive decline, sleep apnea, and depression. Now, see, whenever there is overfeeding, so the fat, the subcutaneous fat, gets partitioned into visceral fat, which is the fat surrounding the internal organs, and ectopic fat. Now, what exactly is ectopic fat? It is something where the fat is not supposed to be stored. So those organs, when they start storing the fat, then they start having problems like liver and pancreas, muscles, and heart. So then you have metabolically obese people who are normal weight. Even they benefit from lifestyle modifications. We should use these LSM as first line or in combination, because if you start straight away with drugs, you will need so many drugs for so many organs. So this is the first thing to start with. Now, I want to take you through a little preview about causation of disease, and please indulge me for this. So here we have pictures of identical twins. They have same genes. These are 3-year-old identical twins. They are genotypically, phenotypically similar. And these identical twins, because they are genotypically similar, are not phenotypically similar. What is different about them is also their life choices and their health issues. So the previous twins, 40 years old, they had the same environment. Look at this agouti sisters. In this experiment, the agouti gene was turned on for this pup. So this pup became obese and yellow. So you created a different environment, and these identical twins, so-called, began to look different. So what shapes you? So is it your genes, which you are born with, which is nature, or is it your environment which you are nurtured in? The link between your genes and the environment is epigenetics. So in this 3-year-old twins, you can see the epigenetic tags here. They are in the same place. But when they are 50 years old, you see different tags at different places. This drift of the epigenetic tags occurs due to external factors. So what are these? These change the function or modify the action of genes, but not the sequence of the genes. So the sequence in the genome is not changed, but epigenetic marks can just modify their action, and they are heritable. So your DNA isn't your destiny, and epigenetics controls the genes. What controls the epigenome? It is the environment. Now, this is a huge environment of which not going to be talking about the toxic cigarette smoking, because not at least further in my talk, because this is taken. Now, what exactly is environment? This is everything outside of yourself and our chemical environment inside, and everything that surrounds the genes. So this is what is the environment. Now, let's come to the components of the lifestyle modifications. We have broadly got them into 5 groups. Exercise is coming up in the next talk. So let's go with diet first. So when we talk of diet, we know that overfeeding and obesity is an epidemic causing so many other epidemics. But what if you fast? If you fast for 10 to 14 hours, the liver glycogen stores do not last. So then the metabolism shifts from glucose to ketone, and alternative fuels are used in the liver, and there's oxidation of the adipose tissue, which leads to fatty acids. The byproducts of this are extremely important chemicals. Most of these are neurotransmitters, which decrease cognitive decline. So the fat which is mobilized first is the visceral and the ectopic. And this is exactly what we want. Therefore, all these issues that we are talking about, they all will improve. So the question is, how can we fast? So you can do a daily calorie restriction by decreasing 30%. You know, you have these charts online and you can just know your calories, whatever you took in that particular day, and try and decrease 30% of that calories per day. This is DCR. Now, as a rough guide, if you decrease your calories 500 kilocalories per day, you're likely to reduce your weight 1 kilogram in 17 days. That is amazing. Now, other than that, you could do intermittent fasting in which you eat at restricted times, but you do not control the calories. You can have as many calories as you want in the time when you're eating. So you can be eating for 8 hours or 10 hours and fasting for the rest. For women, it is generally recommended to stick to a 14-10 schedule. Or you can do an alternate day fast where the fasting days are not consecutive. Or you can have a modified alternate day fast when you can have 20% of your calories or 500 kilocalories on your fast days. Or you can have a 1 meal day. So which of these two is better? The research says that intermittent fasting is far better than DCR, not just in reducing your weight and your BMI, but in so many other factors, ghrelin and your satiety hormones and your hunger pangs. So let's come to the types of diet. Most of the pertinent diets which I'm going to talk about just now is the Mediterranean diet and the dietary approach to stop hypertension, or a combination of the Medi diet with the DASH diet, which is a Medi plus DASH intervention for neurodegenerative delay. This is known as a MIND diet. So these diets are all very good, antioxidant, anti-inflammatory, and the MIND diet is also neuroprotective. Now, I've just listed here the Mediterranean diet and the DASH, the differences. There's not much difference except that the Mediterranean diet allows you moderate amount of red wine. So when it says no added salt, the DASH diet says low salt. And Mediterranean diet focuses a lot on olives and olive oil. So are any of these diets good for Indians living in India? So probably I think you should take clues from these diets. Take what is best out of these diets, but eat what is locally available, which is seasonal. For example, in North India, you can get cauliflower in summer, and it's not grown here. It is coming from somewhere far away. Farm fresh or farm fed. So this refers to not just vegetarian food, but also non-vegetarian food. All brightly colored greens, berries, nuts, raw food, cooked food, high fiber and fermented foods, and no alcohol. So when you say you can take alcohol in moderation, 30 grams for women, 40 for men, the current recommendations internationally are no alcohol, because even if it may have some benefits for cardiovascular, it causes a lot of other cancers and other problems. So your diet, local diet, will give you everything: nutrients, antioxidants, pro and prebiotics. A little sharing about the lessons that we learned from blue zones. Blue zones are these 5 areas which have people living more than 100 years of age, healthy, happy, and mentally agile. Singapore is a modern day blue zone, but the original ones were these 5. So the lessons that we learned from why people are like this is because they don't go to the gym. They move very naturally. Lot of walking, lot of gardening, lot of yard and household work. If they have to visit a friend, they have to go up and incline, come stairs, go up and down. They have purpose in life. They have faith. They take naps, have happy hours, and they eat only 80% of their appetite. Yogic wisdom says eat only 50% of what you're hungry for. And they connect with family, which includes parents, grandparents, children, partners, and your circle of friends. Then come the strangers and society. So if you have people who say we do a lot for society, I think they've got something wrong somewhere. So moving on to reactive oxygen species and oxidative stress, ROS are actually, they have one or more unpaired electrons in their external orbit. Therefore, they are very highly unstable and highly reactive. And they steal electrons from nearby substances. Therefore, they are called oxidants. And the one which loses the electron loses some part of its structure or function. So you see, when there is an emptiness and you take your energy from someone else, it's something like a marriage, no? You marry because you're incomplete, and then you marry, and then you find that that person was also incomplete, so it doesn't work. Now, these redox reactions of reduction and oxidation, they are part of your entire life. Normal healthy systems have both oxidants and reductants which are balanced. And if the oxidants are slightly increased and there is a slight oxidative stress, these ROS are actually used for redox signaling. So a small amount of stress is good, but when it is in excess, it is oxidative stress. And aging cells are more exposed to oxidative stress. I love this particular diagram. It shows you the relationship between ROS and aging. So when the ROS is increased slightly, it improves self-renewal and increases differentiation of these cells, and it counters aging. But if ROS is decreased, the ability to renew becomes less. And if ROS is markedly increased, then you cause stem cell exhaustion and premature or accelerated aging. And it also causes inflammation, cancer, cell death, and a whole lot of age-related chronic disorders. Now, just look at this. If you have an oxidative stress, obviously to counteract it, you will need antioxidants. So antioxidants will donate their electron to the electron-hungry ROS oxidants without becoming electron scavengers themselves. Now, if you look at this, this looks very big, but the actual thing is really huge. You just see natural antioxidants, a few of them are endogenously produced, but most of them you get from fruits and vegetables. And N-acetylcholine converts to glutathione, IV albumin, and melatonin. They are used in liver disorders, so there are some practical uses in clinical work. Now, just a quick glance at this. I give you time to just absorb this. And this is just a list of your sources of antioxidants, which you can use. And we move on to an issue which is a little neglected, and that is about the brown adipose tissue. Now, brown adipose tissue is abundant in newborns, but with advancing age, it decreases. And it is inversely proportional to the body weight. So the lesser the BAT, the more is the body weight. Now just see BAT, the white adipose tissue is actually concerned, is a storage form of triglycerides and fat. But BAT actually uses energy and it expends energy. It increases the BMR and it maintains heat. And therefore it helps you in reducing weight. But adipose tissue is plastic, and you can increase your BAT even as adults by diet, lifestyle modifications, and cold-induced thermogenesis by your temperatures of your nighttime temperatures to 19 degrees just overnight, and some nutritional strategies.
Ma'am, your time is up.
Which look something like this. So chili peppers and menthol and mustard. So you can increase your BAT by some nutritional strategies. The second part is exercise. Now, if you add a cognitive task to a physical or a motor task, you will not only be increasing the physical benefits, but cognition too. Yoga is an excellent example of a cognitive, of a dual task activity, and it has been, excuse me, recommended by WHO as the exercise for aging adults. Then the third pillar is cognitively demanding activities. Some amount of stress is stimulating. Use different ways of solving a problem to increase your cognitive reserve and have a look at all this. The key word here is new. So acquire new skills and training. If you start to learn to sing, it has to be well, but the most research is on piano and drums. Leisure activities also contribute, and social activities are very important because every time you meet people, you have to remember what that person's name is, what did you speak of last time, what about their family, in fact, even what you wore when you met them last. So the fourth pillar is mindfulness meditation, which simply means training the mind to be here now. Remember that brain is a process, it's not a thing, it's trainable. And finally, we come to sleep and melatonin as very important to rejuvenate and repair. And trees, mountains, and water bodies, they resonate with healing centers inside of you.
I'm sorry to interrupt you. Your time is up.
Yeah. Can I have one more slide after this?
Yeah, sure.
So this is a sentence which has greatly impacted me and I must share it with you. Healing can be brought about by changing the host so that the disease no longer recognizes the host. This is scientifically validated. So you can change your appearance by changing spectacles or your hairstyle. Do something when people say you have changed and have an attitude of gratitude, remove fear, and have more social and spiritual connections. So this summary is exactly what part of my talk was. You can just have a look at it. And I encourage you to heal yourself. And my best wishes to all of you. And please be kind to innocent miracle healers. Thank you very much.
Wow. Thank you, Neerja ma'am. It was indeed a great
That was
lecture.
a lovely talk, isn't it, Archana?
Yeah,
Lovely,
sure,
lovely
ma'am.
talk. Yeah.
And we
I
all
was in a delivery. I'm so sorry I was in a
no
delivery.
issues.
Yeah.
I was there as a backup, madam.
Yeah.
Not a
Yeah.
problem.
Yeah. Thank you,
Wonderful. It
Archana.
was
Yeah.
wonderful.
So
It
I
was
think
wonderful. Yeah.
the best thing is that whatever she talks, she practices also herself. So that is the best part. And would you like to sum up, Rakhi
Yeah.
ma'am? I think you're back. And then we can have Maninder ma'am. She's waiting for a long. She's in Melbourne. It's late night. Thank you, ma'am, for being there.
Hello. Shall we move ahead? Shall we
Yeah,
move
I
ahead?
think so.
Yeah.
I think so because
Yeah,
she's
let's
waiting for
move
long.
ahead before we waste much amount of time.
So I think Maninder ma'am, you can introduce ma'am or Rakhi ma'am. I mean, she's a well-known person. I mean, a practicing diva, and if you could, Rakhi ma'am.
Yeah, she is a well-known person all around, and she's been working at length for menopausal symptoms, and she's got a own society also where she is running actively, very actively for that. Who else would have been doing justice for this talk other than Maninder ma'am? She was a founder, vice president, and the president of the Foxy in 2004 and member of lot many publications and lot many conferences to her credit. Without wasting much time, let's hear Dr. Maninder's lifestyle modification.
Thank you, Dr. Neerja. But thanks to Foxy office bearers who made this webinar possible, this rather certificate course possible, because this is the need of the hour, what we need. And Dr. Jaideep Tam, Dr. Madhuri, Dr. Parag Beniwale, Dr. Sheila Mane, and everybody needs our congratulations for this thing. And all these speakers, they have done wonders. They made my job easier because all of them highlighted that obesity is the basic cause of our cancers. to metabolic syndrome, to everything. So we have to deal it. But I must tell you something about Nirja Chawla. She's the one who is very dear to me, and her talk was excellent. The way we can reduce, one of the ways is her way of doing things. Rather, both the things which I say and she says, both have to be combined to have the results. This was in her IMSCON in Chandigarh, where I had given my first talk on prescription of exercise. She said, give it a poster presentation. I said, no way. Just give me 10 minutes, but I have to give a talk. And that was the landmark talk, I think, and the step forwards for me on this prescription of exercise.
Love you, Minnie.
Yeah. And this is the one, my father and they both call me as Minnie. That was my pet name. How it came to her mind, I don't know. But it is now I'm sharing it.
Till Mandy ma'am is sharing, I would like to tell we had WW conference, we had a prescription of exercise along with Zumba and everything. So still that, yeah, is in our memories.
Yeah, I started from the very beginning. Let me see.
First slide, this is the
I'm
conference.
sure I'll have to go here. Yeah, I started from here. I don't. Let me see now. Yes. Yeah, it is late. It's past 12 o'clock at the night. I'm in the Sydney, and I was in a wonderful, wonderful World Menopause Conference. I tell you, we have to learn a lot from the West about how we should be doing the research and how should we be presenting it. And I was the proud presenter of my original paper on the relationship of menopause to metabolic syndrome, and that was taken in a very wonderful way there. So what I'm going to talk about, prescription of exercise. Now, what is happening in reality? I'll have to minimize it, sorry. Yes. We are aging population. But is it a healthy population? Aging? No. If the life expectancy is increased, it's the non-communicable diseases which are occurring. Their occurrence is not delayed. Then that means unhealthy years of life are increased. So that's not good for the society or for the person or the family or anybody. So it's not increasing our health related healthy life years. And this is happening because of the non-communicable disease increase, which all of us know is increasing. I'll have to go from here. So menopause is a physiological process in reproductive aging of women when there is amenorrhea more than 12 months. Now, why I'm talking about it? Because recently there has been a talk, a discussion, lots of discussions going on that there is medicalization of menopause, which is a natural phenomena. So that has come under the lens, and lifestyle modifications are being advocated as the mainstay of management and also early diagnosis and prevention of morbidity. So that is when it should be started early. If we really have to do the prevention, and of course, wherever needed, we have to give menopause hormone therapy. I'll never say it's not needed. Wherever needed, but over medicalization should be prevented. Now, when we talk about physical activity, all the women patients who come to us will say, we are doing some physical activity, but we are get tired, but we are not losing weight. Why? Because there is a difference between physical activity and exercise. Now, in 15 minutes, it's a vast subject. I may not be able to do justice. I'll just be doing the sort of introduction part about the exercise, what the healthcare providers have to know to counsel their patients and for themselves also. So physical activities, any body movement which you are doing in daily routine, our course of household activity or our occupational work or our leisure time activity. But when we are doing that activity, our consumption of energy does not increase more than our basal metabolic rate, what we are using at a resting period. So until unless our intensity of exercise and duration of exercise is to that standard, where our heart is increased, our oxygen consumption is increased, that is called the aerobic activity, then it is won't be called an exercise. So what is an exercise then? It's a planned, structured and repetitive physical activity that has measure of intensity and duration activity. So it can be measured easily. So it's a scientific facts are there. They have been done, the animal experiments, human experiments. What I'll be talking is all there in the papers itself. But I'll be giving you some of the references which you can go and read on yourself also. So the activity which can be measured and has a final or an intermediate objective, the improvement or maintenance of physical fitness. So various advantages of exercise have already been highlighted by our various speakers who have been talking on the menopause. For losing weight is main, for increasing insulin sensitivity is another, for maintaining weight loss is another, healthy survival, longevity is there, prevention of metabolic syndrome, diabetes, hypertension, CHD, cancer prevention, osteoporosis prevention. Of course, Alzheimer is prevented if we start early. Osteoarthritis prevention, that is important. Even in osteoarthritis patients, you advise them, because by doing these exercises, their cartilage thickness is going to increase, and knee replacement will be delayed or prevented absolutely. So help in improving sleep, proper exercise, and sexual health, mood and anxiety, cognition, psychological. Now, I tell you one thing, all these uh, our metabolic processes or our non-communicable disease, they need different type of exercises in different pathologies. Coronary patients might need different exercise, osteoporosis, different exercise. But basically what we'll be talking about will be about the adult women or the midlife women or the osteopenic or osteoporotic women, what sort of exercises should they be doing? So mechanism of action of exercise is very vast. Like already Nisa has talked about epigenetic and genetic changes. Same thing is happening in the exercise also. So they have effect on the muscular level, tissue level, cellular level, mitochondrial level, and epigenetic and genetic levels are there. So as I said earlier, increased age span does not equate with an improved health span. So there is now evidence that environmental lifestyle makes a great contribution towards the health of the women. Physical exercise had the advantage because it's easily available, and which improves the well-being across many health domains, which I've seen in many systems, they help us. And engaging in exercise does influence genes involved in the metabolism and the muscular health and life. So engaging in exercise does influence genes involved in the metabolism, muscle growth, cognition, psychological well-being dependent on intensity of the exercise. So genetic tags, they can act as on and off, as Nija had also explained, by process of methylation, demethylation, acetylation, deacetylation, phosphorylation, dephosphorylation. So basically, many genes are involved, and environmental triggers, they act through many pathways. One of them is NRF2 pathways. Then they can act through other genes also, and various studies are there. So chronic exercise can upregulate endogenous antioxidant effect at cellular stress level. FOXO genes are involved. They are involved through changes in epigenetics in the muscles. Muscles grow through insulin-like growth factor. Muscle need energy, and mitochondrial pathways is somewhere increased. Then telomere length, that is also increased when we are doing the various types of exercises. So this molecular adaptation, I have talked about NRF2 factor, which is there. So how do the physical advantages of exercise are? They increase your endurance, strength building, balance, flexibility. Now, what are these terms? People don't, they get confused. What is the difference between endurance and your strength? So as we age, our strength and stamina indulge in routine activities decrease. So we need this strength and stamina building exercises. Difference between strength and stamina is that in strength, you can lift more weight. Supposing you have to put luggage in overhead in the aeroplanes. So you have to lift up 10 kg of weight. Now, if you have to lift that 10 kg of lift for just 15-20 seconds, that's okay. But supposing if you have to lift that weight for a long time, so that is your stamina. How long you can move on, how long you can carry that weight. Flexibility is of our joints so that we can work full range. Even we can take our hands back and change our clothes and all that. So that is flexibility and range of movement and stretching exercises. Now, basic, the consistent recommendation by all the associations, whether they are ACSM or they are the CDC or the Exercise Physiology Association or Menopause societies, they all give a standard basic advice recommendation for everybody. Moderate intensity aerobic physical activity of more than 30 minutes for 5 days per week. That is 150 minutes total in a week, or at least 20 to 60 minutes of vigorous intensity aerobic physical activity more than 3 days per week. Exercise to improve balance or prevent falls for more than 2 days. Resistance strength training exercise for more than 2 days. Note that ACSM, American College of Sports Medicine, also specifies for older adults or those who were not used to exercise sedentary, then aerobic activity should be at a lower level between the intensity of 5 to 6, and not the moderate or vigorous activity, but at a lower level. And but the resistance training program should be progressive one. Now, so if you start with 1 kg, then you continue for 1 month for 1 kg, then increase to 2 kgs. So that is the strength building has to be a progressive. So all these body movements, they require contraction of muscles. So they need that. They need neural system also in place. And they need these exercises, they increase your vascularity also. There are 640 muscles in your body, and they make about 40% of weight. So if you build them, they will be using less energy as compared to fat when they are resting. So that is one thing important. Now I come to the explanation of the intensity of the exercise. So one repetition maximum, which is the maximum weight you can take for contraction for one type of, supposing you have to flex your muscles, so you can take 10 kg of weight. So what weight should be starting your exercise with? 1 kg, so that you can complete at least 10 repetitions with that weight. So that should be the minimum you should be started. Now, intensity is measured by your heart rate, because your heart rate is increased in response to your these activities, and that you can always check up by these smart watches, because they will show you heart rate. So how we calculate it? Simple formula: maximum heart rate is 220 minus age in years. And for 50 years, that will be for moderate active 170. 220 minus 50 is 170. For 60 to 75% of that will be between 102 and 127. And for vigorous activity, that will increase to 85 or 102. So that is the so person's target heart rate be 70 to 85% of that maximum heart rate. So when the people go beyond this heart rate, then they have the heart attacks. That is when they collapse down. So talk test is another test where you should be able to talk when you are doing an exercise that is a mild. If you are not able to talk or you are not able to sing, then that's a moderate. And when you are not able to talk at all, then you are doing a real vigorous activity. Then self-perceived exertion. On a scale of 120, you feel whether if you are feeling now stretched out or not. So that is self-perceived exertion, and that should be in between 14. Then another where you can see how much you are actually is pedometers. So this less than 5,000 steps per day are sedentary behavior. 8,000 to 10,000, a moderate active lifestyle, and beyond that is when you lose weight also. Again, these watches, they are going to help you. Another is the MET calculation. That's a difficult, because MET calculation is your 1 unit per minute while sitting. That person is using, if person is 70 kg weight, then 70 kilocalories there she is using while sitting down. And this is a very important website where you can go, where the compendium of all the activities is there. So whether you do cycling or you are walking or you're doing resistance training, your homework, you're doing lawn mowing, bicycling. So they have given you MET for all these exercises. So you calculate MET as 3.5, whatever the MET for that exercise is there, into 3.5 into body weight in kgs, and divided by 200 will be the kilocalories used. So this is one example where bicycling uses MET of 12, 8 is there. So they are using for 1 hour and weight is 50 kgs. Then the person will be using 7 calories per minute, and for 1 hour they will be using 420 kilocalories. So that is how the calories are being used, because if you lose 500 calories per day for 7 days, then you can lose 1 kg of weight. But that is what you divide between your physical activity and your dietary goals also. So that is how intensity of exercise. Now, what are these exercises? Some examples of aerobic exercises where your heart rate is increased, your oxygen capacity is increased, and you are using the kilocalories, the energy consumption is there. Walking, bicycling, stationary cycle, dancing, treadmill, cross trainer, running. They are all examples of aerobic exercises. Now, they are not going to build up your muscles. If you have to build up your muscle, then you have to do resistance and weight training.
Ma'am, your time is up.
Okay.
Yeah.
So our home exercises, we can do all these exercises in the home with the help of these armamentarium, dose prescription, as I've said. This will be the one slide more. For maintaining and improving health, 150 minutes. For prevention of weight gain, 150 to 220 minutes of moderate activity, and promote clinically significant weight loss, 225 to 420 minutes per day. So they are important exercises for fall prevention, for osteoporosis prevention. So we have to introduce this strength training has to be included along with aerobic exercise. So multi-component exercises should be there, including resistance and impact exercises to have the full effect on the health. It is very important to achieve the peak bone mass density, because if women don't achieve that, then they will be entering menopause with already deficit, and they will have more chances of osteoporosis as they are entering menopause into the osteopenia only. So this is all I have cut down on this. Just one slide. How much should be the intensity for these adults? That will be jumping exercises, because they use 3.5 times of your body weight, and walking just uses 1.5 times of your body weight, and jogging 2.5 times of your body weight, at least 150 to 100 impacts per day, 3 days in a week, and for more than 7 months, then only you are going to have your impact. So how much you can lift is, we have already talked about. So just the last slide, this is the last slide. What is effective of applying physical activity to improve? Just do it in the proper way. That is very important. And it is not that you have to go to gym. I've told you can do these exercises with the help of various equipment at your home, but you must be trained initially by some trained personal should be there. And it is time that I should start concern. Tai Chi, engaging social activities, line dancing, they are all the exercises which can be included into your daily lifestyle. Thank you very much. I think whatever I could achieve in 15 minutes, I've done that.
I would request the chairpersons to please give their comments.
Yes.
Rakhi ma'am.
I think
So
Dr.
can we move
Rathi
on?
was traveling. Yeah.
Is Dr. Neeraj Jadhav there?
Neeraj has also left. I don't know.
No, I think Dr. Neeraj Jadhav is there, na? His is the next doc, yeah.
So moving
Yeah,
on to our
Yeah, Neeraj is there. Neeraj is there.
Neeraj
Yeah.
Chawla is the one who had given.
I'm here.
Yeah. Excellent talk, Maninder. And I think we must have one practical session by you because that
Yeah,
will benefit us more.
I think these are more should be workshops rather than the topics. But of course, theoretical knowledge has also to be there.
Yeah. We must
Anyway,
have
thank
midlife
you very much
workshop.
for giving
Thank
me
you.
this opportunity
Yeah.
for
Thank
making
you.
it official course
Thank you.
material. Thank you.
Please introduce the next speaker. Chairpersons, please
So
introduce.
after a great session, second session, we move on to session 3, which
Yeah.
will be which has 2 talks taken by Dr. Neeraj Jadhav on sexual health and on postmenopausal bleeding by Dr. Sarita Bhalerao. This will be chaired by Dr. Meena Samat ma'am. She is senior consultant at HOD Department of Obs and Gynae, Kurji Holy Family Hospital, Patna. She is president Patna Obs and Gynae
Thank
Society.
you. I think we should move on. Yeah.
And also
our next chairperson is Dr. Komal Chavan. She is
Yeah.
also there, ma'am.
Yeah.
She is vice president elect.
Yes,
And
thank you so much. I think we should move on.
Yeah.
Everybody's getting
Please
so
introduce the first speaker, either Komal or Meena. Please
Yeah,
introduce Neeraj. Yeah.
introduce. Can I have
Yeah.
the CV?
Yeah,
The
please
first
go ahead.
speaker is
Yeah.
Dr. Neeraj Jadhav. So great pleasure. Without any delay, we call upon Dr. Neeraj Jadhav, who has done the fabulous work as a chairperson of Sexual Medicine Committee, for which he has also won the Best Committee Award. So over to you, Dr. Neeraj Jadhav, and you can begin your talk.
Thank you, Dr. Komal and Dr. Meena, for chairing my session. Let me share my screen. It's visible?
Yes,
Hello?
sir. Yes,
Okay.
It is visible. Yeah.
You can go ahead.
So, topic given to me is the very close to my heart, that is the sexual health, and menopause and sexual health is the topic given to me. So, when patient enter in the perimenopausal age and menopausal age, they are at a very transitional phase where sexual health is going to take so many changes in their life. Although sexuality remains an important component of emotional and physical intimacy that most men and women desire to experience throughout their life, sexual dysfunction in women is a problem that is not well studied. It is unfortunately a topic many healthcare professionals have difficulty raising with their patient. There are so many factors responsible for that. There is a lack of training, lack of skill, lack of time, fear of embarrassing patient, lack of treatment to offer, belief that sexual interest decline with the age, and sometimes personal issue belief also comes in the way while tackling such type of patient. So communication with the midlife patient is very important. Encourage patient to talk about their sexuality concerns, but be very open and non-judgmental. That is very crucial. And address the always address the sexual problem as a couple issue, not a individual issue. Regardless of age and menopausal status, sexual interest continue for many women. 76% of the middle-aged women, according to one survey by the Swan, sex was moderately or extremely important to them. So most of women still have a very much sexual interest in postmenopausal age also. Increasing recognition of this common problem and the future research in this field may alter perception about sexuality, it dismiss taboo and the incorrect thoughts on the sexual dysfunction, and spark better management for patient, allowing to live more enjoyable life. So onus is on us as a gynecologist. Sexuality is an important component in the life of menopausal women, as an increasing number of women who are now passing through the menopause are complaining of the diminished or no decreased desire to have a sex anymore. And the advancement in the treatment of male erectile dysfunction in combination with a longer life expectancy has raised couple expectation to maintain the healthy sexual functioning. So what is sexual health? Sexual health is a state of physical, emotional, mental, and social well-being related to sexuality. It's not merely the absence of dysfunction or infirmity. Female sexuality, according to WHO, is not only an important component of women's health, but also a basic human right. So this should not be the situation when patients enter into the menopausal age. Sexual functioning during midlife is a multifaceted and swayed by the hormonal and non-hormonal factor. The association of the importance of sex with all domain of sexual function suggests that the asking patient about the importance of sex may be a cornerstone for the management of the sexual concern in the midlife woman. Sexuality may impact quality of life through effect on the emotional and psychological health of a woman. The menopausal transition is often associated with the sexual dysfunction. The physiological mechanism by which the menopausal transition affects the sexual health involves the declining and the fluctuating gonadal steroidal hormone level, which adversely affect the elasticity of the vaginal mucosa, vaginal secretion, and result in the vaginal atrophy and pain while having a sexual intercourse. Additionally, social conditions or life stressors like divorce, lack of partner, job loss, or declining health also may affect the desire for the sexual intimacy. There are various factors which can affect the sexual function in the menopausal age group, like biological factor, psychosexual factor, and the contextual factor. Biological factor like gynecological or surgical intervention, premature ovarian insufficiency, endometriosis, iatrogenic menopause, and endocrine factor. While psychosexual factor like perception about the menopausal changes, loss of sexual confidence, affective disorder, distress like personal, emotional, occupational, partner-related distress, all can have an effect on the sexuality in this age group. And partner's general health and sexual problem also can have an impact. And there are contextual factors like ethnic, cultural, religious expectation, and the constraint, support and network, life stressor like divorce, death, and economic hardship can also have a bearing on the sexuality during menopause age group. So female sexual dysfunction can occur at any age, but it is most common around the middle age. Two important overlapping factors that affect the female sexuality are the aging process and the menopause. Female sexual dysfunction is a multi-causal and multidimensional problem combining the biological, psychological, and interpersonal determinants. It has a major impact on the quality of life and interpersonal relationship. Despite the widespread interest in the research and treatment of the male sexual dysfunction, there is a less attention has been paid to the problem, sexual problem about the woman. So sex steroids play a major role in positively modulating the sexual behavior, mood, emotion, cognitive through a woman's lifespan. Declining level during the perimenopausal and extremely low level in the postmenopausal age have a detrimental consequence on the overall and the sexual well-being. Menopause-related low sex steroid level cause changes in the activation of the certain brain area, causing a decrease in the sexual arousability. Estrogen loss also diminishes the cognitive function. And now androgen also is important. Androgen recently come back into spotlights as a pivotal regulator for the female sexual health. Indeed, studies indicate that the estrogen and androgen exert a synergetic stimulatory effect on the female sexual response, promoting the sexual desire through a complex network of neurotransmitters and balance between the excitatory and the inhibitory signals. Notably, testosterone circulates at the higher concentration than estradiol during the both pre and postmenopausal year. Androgen decline is aging related rather than the menopause related. Female sexual dysfunction implies that persistent or recurrent problem encountered in one or more stages of the sexual response. It is not dysfunction unless the woman is distressed about it and it negatively affects the relationship. Female sexual dysfunction, if you want to classify, it can be classified as a sexual desire disorder, like hyperactive sexual desire disorder or sexual aversion disorder, then sexual arousal disorder, Then comes the orgasmic disorder and the sexual pain disorder like dyspareunia, vaginismus, and other sexual pain disorder. In 2030, there is a DSM-5 classification came in picture where female hyperactive desire disorder and the female arousal disorder have been combined in a single entity, that is a female sexual interest or arousal disorder. Female orgasmic disorder remains same, while dyspareunia and vaginismus have been combined in a single entity as a genitopelvic pain or penetration disorder. There is a recent classification of DSM-5 about the female sexual dysfunction. How you define the female sexual interest or arousal disorder? There are 6 criteria. Out of these 6, there should be 3 should be there. Absent or decrease in the sexual interest, absent or decrease in the erotic thoughts and fantasies, absent or decrease in the initiation of the sexual activity or responsiveness to the partner's attempts to initiate sexual activity, absent or decrease in the excitement and pleasure during the sexual activity, and the absent or decrease in the arousal in response to the sexual cue, which may be either written, verbal, or visual. And last is the absent or decrease in the sensation during the sexual activity, whether genital or non-genital. So out of these 6, at least 3 should be present before you label as a interest or arousal disorder. And one important thing is it should be present at least for the 75 to 100% of the time. It requires minimum duration of the 6 months, and it should cause the distress to the person and to the partner, to the couple. Coming to the female orgasmic disorder, it is characterized by persistent or recurrent distressing compromise of the orgasm, frequency, intensity, timing, and or pleasure associated with the sexual activity for more than 6 months. Frequency, orgasm occur with a decreased frequency or it is absent. Intensity, when orgasm occur with the less intensity. Timing, when orgasm occur too late or too soon. And pleasure orgasm occur with the absent or decreased pleasure. So that is a female orgasmic disorder by definition. Sexual pain disorders such as dyspareunia are described as a recurrent or persistent genital pain associated with the sexual intercourse. The most common causes are infection, surgery, medication, endometriosis, and the interstitial cystitis. And vaginismus is the recurrent or persistent involuntary spasm of the musculature of the outer third of the vagina that interfere with the vaginal penetration and that cause the personal distress. And chronic diseases such as hypertension, diabetes, depression, neurological disease, urinary incontinence, and osteoarthritis commonly affect the sexual function. Reduced physical function in obese women and the women with the osteoarthritis may also adversely affect the sexual activity. Additionally, sexual dysfunction observed in the women with diabetes is attributed to the reduced energy, altered body image, and the suboptimal vaginal the orgasm. So there are some medication also which can affect the sexuality in this age group, like antidepressant, cardiovascular medication, hormonal preparation, neurological medication, steroid, anti-epileptic, antihistamine, anticholinergic, all can have an effect on the sexuality in the patient. And when patient is present with the sexual function, there is sometimes, most of the time, there is a overlapping of the 2 sexual or 2 or 3 sexual dysfunction. It can be have a desire disorders, arousal disorder, orgasmic disorder, vaginismus, or dyspareunia, but it overlaps most of the time. So coming to the management part, there are 2 modalities. One is the psychological counseling and one is the pharmacotherapy. Treatment should be individualized, taking into account the severity of the symptoms, medical condition, potential adverse effect, and the patient's personal preferences. Psychological counseling is very important. Psychological intervention are excellent initial tool for addressing female sexual dysfunction, and usually biomedical and psychosocial interventions are combined to provide an optimal outcome. However, one of the barrier to this type of approach is what is known as a treatment resistance, because it takes long time and patients sometimes opt out of the treatment when we put patient on the psychological therapy.
Sorry to interrupt, sir. We are shooting time, sir.
Yeah. Psychological counseling solely or in combination with the medical treatment can be helpful to women and couples suffering from the sexual dysfunction. And issues such as relationship distress, extended period of sexual abstinence, sexual abuse history, lack of sleep, taking care of an elderly parent can all have an impact on the sexual functioning. And behavioral exercise may also help individual to reduce anxiety associated with the sexual problem. This I'm skipping because lack of time. Coming to the pharmacotherapy, there is most what options available to us are the moisturizers and lubricants, estrogen, androgen, DHEA, tibolone, selective estrogen receptor modulators, and some newer technique. Vaginal moisturizer and lubricants is recommended as a first line of treatment in mild to moderate vaginal dryness and where local estrogen treatment is contraindicated. It is available. Moisturizers have ability to retain and accumulate water, which is then released locally, resulting in an increased hydration, thus mimicking the physiological vaginal secretions. This provides a quick relief of local symptoms, especially dryness, and clinical benefit lasts usually up to 2 to 3 days longer than the lubricant. Lubricant is for the short duration. Lubricant, while moisturizers are intended for chronic maintenance to replace vaginal secretion, lubricants are specially designed to reduce the friction during the coitus and reducing the dyspareunia. There are various lubricants available like water-based, then water-based and pH balance. Then there is a silicone-based lubricants and glycerin-containing lubricants is also available in the market. Then we all know about the estrogen therapy. Estrogen, they cause vasodilatation and increase in the vaginal, clitoral, and urethral blood flow via nitric oxide synthesis and the vasoactive intestinal polypeptide pathway. They are available as a tablet, cream, or ring. How to put patient on the local estrogen therapy? A typical administration schedule consists of an initial dose to be taken for approximately daily for 2 weeks, then followed by transition period or to maintenance therapy twice a week, as long as needed to manage the dryness. Venous thromboembolism, we all know, is a side effect. Then there is a L-arginine gel is also available to help such type of patient. There is a selective estrogen receptor modulator like fosfamifene and benzodiazepine. Then coming to the testosterone. Testosterone is not only the hormone of sex drive and libido, but also considered as important for the woman's physical and mental well-being. It is available as a patch, cream, and the gel form. Various studies are available that where it shows that the testosterone is a can be put we can put patient on the testosterone and it will improve their sexual health. Then there is a DHEA. Usually, tablet form is not that much effective, but DHEA gel, vaginal gel is most preferred mode of treatment in such type of patient. Then synthetic steroid, tibolone, where estrogen is contraindicated, also improve the sexual function. Dose is 1.25 to 2.5 milligram per day. Then recent modality, we all know about the cosmetic gynecology. There are energy-based device. Then there is a minimal invasive procedure and some surgical procedure. All comes in the different modalities of the cosmetic gynec. What they do basically, they provide women's confidence with the self-body image. They improve and awareness and awakening of the female sexuality is basically their role in the sexual health in the menopausal age group. So I'm skipping this. And in conclusion, sexual dysfunction in menopausal women is a common and characterized by unique detriments and risk factors that go beyond estrogen deficiency. Nevertheless, sexual issues in menopause are underdiagnosed and undertreated. Education of the both healthcare professional as well as patient is crucial, as there is a general lack of awareness that many options are available now, and treatment should be individualized, taking into account the severity of the symptoms, effect on the quality of life, potential adverse effect, and the personal preferences. So that should be our target, that to make our menopausal age group sexually also satisfied when it comes to their quality of life, because it will improve the quality of life, basically. So thank you for your patient hearing.
Thank you, Dr. Neeraj. That was a very extensive narration that you've given, and I think it's so very important for the women. And I think throughout your tenure, you have really educated us on that. So let me introduce now Dr. Sarita Bhalerao, who's our next speaker, who's going to talk on AUB in the postmenopausal period. And of course, Dr. Sarita Bhalerao to this audience does not need introduction. As we all know, she is the secretary of ICOG, which is the academic wing of the FOXY. She's the president MOX 21 to 22, joint secretary FOXY 2070, quiz committee chair to the FOXY 2009 to 11, past president ANWI Mumbai branch, past chapter secretary IMS Mumbai chapter. Madam, over to you.
Yeah, hello. Thank you, Dr. Meena Samant, for that kind introduction. Can you hear me and can you see my slides?
We can hear you and we can see your slides.
Okay, thank you so much. My topic for today is postmenopausal bleeding, and I'm going to cover a few things and practical points about how to manage this condition. First is, how do you define postmenopausal bleeding? It is uterine bleeding occurring after 1 year, at least 1 year of amenorrhea. Remember that 1 to 14% of these patients will have endometrial cancer, and the variation is because there are different studies and because there are different age groups. The closer they are to menopause, the less chance of cancer, but older women, there's a higher chance. Majority of these women will still have a benign cause of bleeding, and the most common cause is genital atrophy. Prompt and effective evaluation is necessary to exclude precancerous or cancerous lesions of the genital tract. To tell very quickly, a good history should be taken. When was the menopause? What is the parity? And what are the cofactors? Are there problems like hypertension, diabetes, any family history of cancer? Are they using anticoagulants? History of drug intake? And on examination, please take up BMI, pap smear, look for cervical pathology, vulval, vaginal causes, and rule out any bleeding from other sides. Sometimes patients confuse whether it's from the urethra or whether it is from the rectum. The first investigation is always transvaginal sonography. It is easy to do in gynec settings, and the uterus should be visualized in the sagittal plane. The endometrium should be measured at the thickest part. The endometrial echo should be seen from the fundus to the cervical canal. Endometrial fluid should not be included. And almost 40% of patients with increased endometrial thickness will have polyps or hyperplasia. In some patients, TVS is very difficult, like obese patients, also patients where there is myomas and endometriosis. And remember that the probability of cancer is very low in women under the age of 50, but rises steadily and goes to 25% in women over the age of 80. So the age is very, very important. And this is a very nice meta-analysis which looked at many different studies, and they looked at endometrial thickness and cancer findings in postmenopausal women with bleeding. And they found that when the endometrial thickness is 3, 4, or 5 millimeters, the number of cases of cancer is much lower. And they say that the negative predictive value is high. So you can see that when you have an endometrial thickness of 4 or 5 millimeters, the negative predictive value is very high. This was another study which looked at the composite data of misdiagnosis of endometrial cancer based on different thresholds. And when the endometrial thickness is 3, 4, or 5, 1 out of 300, 1 out of 200 cancer may still be missed. So there are unusual cancers. And if the patient, in spite of a low endometrial thickness, does have continuous bleeding, then they must be evaluated with a hysteroscopy. So the ACOG committee opinion says that if an endometrial thickness of 4 millimeters or less is there, it has greater than 99% negative predictive value for endometrial cancer. Now, what are the recommendations? If it's the first episode of bleeding, if the endometrium is thin, then no further evaluation. Keep patient under observation. If there is persistent or recurrent bleeding, then additional evaluation is warranted. If there are high risk factors like obesity, PCO, type 2 diabetes, agas, or family history, then endometrial sampling must be done. And thin endometrial echo may still be seen in rarer cancers. Saline infusion sonography may offer advantages. What if the patient is asymptomatic and has a thickened endometrium? Here, commonest pathology is endometrial polyps, but they should be evaluated, and hysteroscopy is an easy, safe, and effective method for investigating these patients. What about outpatient endometrial sampling? Though it is a quick, inexpensive, simple technique, it is a sensitive technique because these cancer cells are friable and they are picked up easily in the endometrial sample. But insufficient tissue is common, and in postmenopausal patients, to negotiate the cervical canal PIPEL may not be possible, and adequate samples may not be achieved in almost 1 out of 4 patients. So there are some disadvantages as well. And the gold standard for endometrial sampling is the hysteroscopy. With the hysteroscopy, it's under vision. A directed biopsy can be taken. Polyps can be removed. It can be done outpatient or office versus inpatient with GA. In our settings, I think, and in postmenopausal patients, inpatient with general anesthesia is better. And today we have 2.9 scopes with small diameters, and it is much easier to negotiate through the cervical canal. In certain cases, you may want to do MRI. MRI is very good for endometrial pathologies, contrast enhanced MRI, because it can also tell you myometrial invasion and surgical planning. And patients say who are elderly patients at high risk of GA, you don't want to give them anesthesia twice. This may be an option to do. And of course, we can follow it up with a hysterectomy frozen section, which was exactly what was done. In this patient, she was an elderly lady, 70 plus, came with a massive bout of vaginal bleeding, and we did ultrasound, we did MRI, we found that it looked like a tumor, and therefore she went for a hysterectomy with frozen section and lymphadenectomy. A special subgroup of patients are women on MHT. Sequential MHT patients will have regular withdrawal bleeding after stopping progesterone. Those who are on continuous progesterone and estrogen may have irregular bleeding for the first 6 months, but this should cease after 1 year. And remember that sometimes patients are on phytoestrogens and they are also weak estrogen. They could cause bleeding. So it's very important to ask them what medication they are taking. Women on tamoxifen, we have many women now who are breast cancer patients. They are on tamoxifen, and tamoxifen is anti-estrogenic on the breast, but estrogenic on the uterus. There's an increased incidence of endometrial pathology. 50% of patients will have an ET of 8 millimeters or more, and therefore the 8 millimeters is suggested as a cutoff for endometrial sampling. Endometrial polyps are more. The incidence of cervical carcinoma is 6%, and the duration of tamoxifen use is important, so they should be evaluated. And there's a very beautiful paper on endometrial thickness in tamoxifen-treated patients, and you can always read this paper and go through it. And this is just to show you the hysteroscopy picture. What we are following is, yeah, you can see the entering the cervical canal. This is with saline distension. There's a dirty looking tumor seen, and this is a case of an endometrial CA. And these hysteroscopy is safe. There were concerns earlier about whether dissemination of cells, but today we have enough data to show that hysteroscopy is a safe investigation. And the important thing is not to raise the pressure too much, to be quick and to take the biopsy quickly and come out, but it's better than doing a blind procedure. Today, there is no room for doing a blind procedure because you may miss the growth that is there. So now I'm going to the next case, and this you can also see. This you can see a nasty looking polyp, and you can see that this polyp, but this was a benign polyp, and the polyp is being detached at the base with the scissor. So the good thing is that you can see the tissue, you can remove the polyp, you can remove the cause of bleeding, and also you can take a good biopsy. So moving ahead, this is a management of women and it's with postmenopausal bleeding, and it's a very good evidence-based guideline, and it tells you that postmenopausal bleeding, you should first evaluate carefully in the clinic with a history and ultrasound and pap smear, see if they have risk factors or no. If the patient has an ET less than 4 millimeters with no risk factors, maybe you can wait and observe and reinvestigate if bleeding occurs. If they are in the high risk group, older age group, and obese with hypertension, diabetes, then they require endometrial sampling. Ideally, the best way to do endometrial sampling is a hysteroscopy in the with a targeted biopsy. But in sometimes an outpatient sampling can be done. If the tissue is insufficient or it is not possible, then they must have an inpatient hysteroscopy with endometrial sampling. With that, I thank you very much for a patient hearing.
Thank you so much, ma'am, for that really informative lecture. I would request the chairpersons to please give their comments.
It was a very comprehensive and very nice talk by Dr. Sarita Bhalera, which has covered every aspect. I'm not seeing any questions. I think we can just finish the talk because everybody's.
Yeah, I think you can go ahead then to the next talk and then for the I think we have finished, no?
We have finished, ma'am.
Finished. So we can
We
go
are
for the
done.
post
We are
test.
done. We have to go
Yeah,
for
yeah.
the
Then
post test,
please
Sarita.
go for the
We have to
post
go
test.
for the
Please.
post test. Yeah. Yeah.
So
Post
thank you
test.
so much, Dr. Shobha Gudi, for the
Yeah.
invitation. And
Thank you, Komal, for coming. I know it is a practice time for everyone, but I'm so grateful. Meena, thank you very much. Komal, thank you very much. Yeah.
Dr. Parul Kochadawala and Dr. Sarita Bhalera for the invitation. Thank you.
Please share the post test in the chat box. Yes. So 10 minutes are over. I think forms have been submitted.
Archana ma'am, can you read out the questions?
Yeah, sure. So the first question is, vasomotor symptoms are biomarkers of estrogen deficiency.
Archana, read the answers as well.
Impaired,
Archana, read the answers as well
the
for the
markers of
benefit.
impaired cardiometabolic conditions. Then FDA approval non-hormonal treatment for vasomotor symptoms is fezlonitan. For perimenopausal women with irregular menses and several severe hot flushes, preferred regimen of MST is sequential combined MST. All regular preparations can be used for vasomotor symptoms in postmenopausal women except ethinyl estradiol. So the fifth question is, which one of the following statements about epigenetic marks is false? They can change the sequence of genes. Which of the following statements is false? The best diet for Indians is Mediterranean diet. So the next question is, which of the following statement is false? White fat is increased in cold temperature. Which of the following statements is true? Testosterone therapy is post-menopausal women is not FDA approved. Please roll on the questions. So next question is, which exercise should be avoided by those above 50 years and osteopenia or osteoporotic patients? The answer is twisting and forward and backward bending. Next is, please roll on the questions. Exercise brings epigenetic tags for healthy aging through which genes? All of the above. Which of the following exercises are needed? Which, excuse me, which of the exercises are needed for building up bone mineral density and for preventing fall? Again, all of the above. What is perimenopause? The period from onset of features of menopause till 1 year after menopause. So the next question is, which of the following statement is true? The climacteric is perimenopause plus a variable period before and after it. The initial straw classification of 2001 had how many segments? The answer is 7. Next question. The initial straw classification 2001 -2 and -1 stages include menopausal transition, which is not a supportive criteria in straw plus 10 classification. That is LH. The next question is, migraine should not be considered as contraindication to use HRT by women with polycystic ovarian insufficiency. Answer is true. Life expectancy in POI is 2 years less than those who attain menopause over 55 years. That is true. Which of the following investigations is not recommended in a case of postmenopausal bleeding? Answer is serum estradiol levels. And the last question is, endometrial thickness of what millimeter or less in women with postmenopausal bleeding has greater than 99% NPV for endometrial cancer? The answer is 4 millimeter. So I would request now Dr. Shobha Gudi ma'am to please give the concluding remarks.
Yeah, thank you very much, Archana, for reading out the questions. I hope, am I audible, Archana?
Yes, yes, ma'am. Yes, ma'am.
Yeah, because I just came home after an emergency. No, I'm really sorry. In between, I was not there for one talk, I think, and I thank Archana for Archana Dwivedi for filling in for me. Actually, today's today was excellent deliberation of so many topics. We learned quite a few new things, and tomorrow morning I think I have to sum up on the scientific content of today's talks. So I will not take time on that now. I only thank everyone for being present here consistently throughout. I thank Dr. Parul, Dr. Parag, and Dr. Sarita Bhale Rao and Dr. Sheila Mane for giving us this opportunity to successfully conduct the first day. Today, the timing was a little off, isn't it, Archana? But tomorrow we shall do better. So with those few words, let us conclude. Is it okay? Or Archana, you want to add anything?
So, Shobha, thank you very much. Archana,
Yeah.
thanks a lot.
Thank you, Ambuja ma'am. Thanks a lot for accepting. Wonderful talk. Yeah.
Thank you very much. And very well conducted session. Hip hip to ICOG. Do it very well.
Thank you, Ambuja ma'am. Thank you. I
Thank
think
you,
Nilima,
Dr.
we can.
Shobha.
Is Sarita there? Is Sarita there? Yeah, thank you, Lakshmi. Thank you, Lakshmi.
Thank you, Shobha. Shobha
Yeah.
and Archana Dwivedi. Thank you for the opportunity. Thank you.
Thank you, Lakshmi. Thank you. Archana, is Sarita, Dr. Sarita there, or shall we conclude? I'm not seeing her.
I think yes, ma'am.
Yeah. So, Nilima, shall we conclude today's session? I thank all the MOCs. Brilliant work by the younger brigade. they really took it on so well and conducted every session extremely well, including the timing, Archana. I was amazed at how sharp they were with the timing. The problem was we started late. Otherwise, no, we would have finished in time. Okay then. Archana, you can tell Nilima to.